Good afternoon, everybody. Welcome to the meeting of South West London Integrated Care Board. I'd like to welcome Jamal Butt, who has been appointed to the board as a non-executive member. Jamal, welcome. I'd also like to welcome Andreas Kirsch, who's our new local authority member. This would be his first board meeting. Sadly, he's unwell, so won't be joining us for this meeting. I'd also like to make a thank you on behalf of the board and personally to Mercy, who has been non-executive member with us since the start of the Integrated Care Board, and her term is coming to an end in December. Mercy has chaired our Quality Committee and has been through a fairly tumultuous time within the Integrated Care Board, including sort of a lengthy period when we didn't have a chair, and undertook a whole range of additional duties in that time. So a big thank you to Mercy. Just a reminder, this meeting is being broadcast online and is being recorded. The recording will be uploaded onto the ICB website, and a version of British Sign Language will also be produced and uploaded. Can members remember to use their microphones when speaking for the benefit of people at the meeting as well as for the recording, and a hearing loop is available for anybody should they need it. Just as a point of order, this is a meeting held in public, not a public meeting, but we will create opportunities at the end for any questions, including those that have been submitted in advance, or if there are questions on the day, time permitting. Just to let you know that it wouldn't be a proper board meeting if we didn't have a fire alarm in the middle of it. We're expecting that to go off at 2:30. It is rather loud, but it doesn't last too long, and we just sit through it. If the fire alarm should go off at any other time in the meeting, then members of staff will usher you to the emergency exit, the stairs, and to the assembly point outside the building. We've had apologies, as I mentioned, from Councillor Andreas Kirsch. We've also had apologies from Shannon Catayo, from Jeremy D'Souza, from James Blythe, and from Martin Spencer. Ben, can I check the meeting is quorate? Thank you. So we'll move on to declarations of interest. There's a published list of interests attached to the papers for this meeting. Can I just confirm that no members of the board have any additional interests that they need to declare? Thank you. Moving on to the minutes of the last meeting, which was held on the 18th of September. Can I check that everybody is content for me to sign off those minutes as a true and accurate record? Thank you. We'll approve those minutes, and there are no actions brought forward. So we'll move on to decisions made in other meetings. Sarah, can you outline these for us?
Yes, thank you, Chair. So there were two decisions that we made in September in our Part 2. One was a ratification of a decision that you took, Mike, as Chair's action around the award of children's therapy services to 4 schools in Wandsworth, and the other one was approval of the recommendation of the procurement panel to confirm the preferred bidder for 2 APMS contracts in Croydon.
Thank you, Sarah. People content to note those. Fantastic, thank you. Now move on to the Chair's report. And as you'll see, we've already announced a number of changes in board composition. As the month progresses and as we move into the new year, we will be adding further non-executive members and associate non-executive members to the team. And it lists those. So we will be welcoming Dr. Masood Ahmed from the beginning of December, and we'll be welcoming Anne Rainsbury from the 1st of January. pleased to say that we've now also been joined by Bob Alexander as an associate non-executive member and by Omar Daniels as an associate non-executive member. So that's sort of the key board changes at this point. I also wanted to highlight just a couple of visits that are made. The first one that I wanted to highlight was I made this with Mark Creelman to the Battersea Field practice, which is in the middle of the Doddington estate in North Battersea. An area of, in spite of the affluence of Wandsworth overall, an area of really quite extreme deprivation. And it was really encouraging to see the amazing work that was being undertaken by that GP practice, and including their work with on what was formerly called the Brazil model, which is a community engagement door-to-door programme of work supporting these very vulnerable communities and excluded communities in accessing the appropriate healthcare. Really, really exemplary project. Really pleased to see it, and really pleased to see the amazing energy in the room. One other thing that it probably is worth noting, as we were looking around and looking at the challenges of space, what was clear was that the NHS and different parts of it own considerable amounts of estate which are currently underutilised. I'm not looking particularly strongly at Jacqueline at this point, but right next door to the Battersea Field practice is a former community site, still owned by St George's, which would be an amazing resource to add to the health portfolio of primary and community care in that part of the world. So I think there are some conversations about how we utilise some of the pieces of our estate. And that is not putting you on the spot, Jacqueline, too much, and I'm not expecting you to respond, but I think it's a broader issue for us because we do have a whole wealth of NHS community estates, some of which is bursting at the seams, others of which is sadly underutilised or non-utilised, as is the case with that particular practice. The other thing I wanted to do was mention a visit that Helen and I made to San Rafael's hospice, and it's part of a programme of visiting our hospices across southwest London. They are really, really important part of the overall provision of care in southwest London. It was a real pleasure to see the organisation, the care and the compassion that they provide to people in the last days of their lives, and to the families of those people. Really good to see that we are able to support them. Of course, there are always financial challenges at the level of support, but it was really encouraging to see and to work with them. So just wanted to call out not just St Raphael's, but all of our hospices as really important partners to the NHS in delivering care, particularly at end of life. That was all I was going to say on my report. Very happy to take any other comments from people, but I assume that we would prefer to move on to the next substantial item, which is the RM Partners Cancer Strategy for North West London. So, Callie.
Thanks very much, Chairman. Can I let Susan Sinclair and Dr. Lucy Hollingsworth in? Come on in, and I'll introduce them. I think we're going to do a sort of triple presentation. Right, just while they're stepping down, just to introduce Susan Sinclair, who's the Managing Director of RM Partners. I think board members know, but just to say, RM Partners is our cancer alliance for South West and North West London, connecting... Thanks, Mercy. So Susan is our Managing Director for RM Partners. Dr. Lucy Hollingsworth is a GP in Central and West London and Deputy Medical Director of RM Partners Cancer Alliance. This is one of 21 cancer alliances countrywide, and its purpose is to really focus on improving both prevention, so reducing incidence, improving the earlier diagnosis of cancer, closing the deprivation gap, and sort of transforming survival ultimately for patients across southwest and northwest London. So it's our local system vehicle for cancer. What I was going to do is just sort of give a general introduction. Susan is going to talk about achievements to date. We've been going for a little bit, but now is the time to bring the latest proposed strategy for 2025-2030 to the ICB board. And then Lucy, I think, is going to cover the look forward. So if I just sort of start with the context, some of the key issues for us, which won't be a surprise to anybody here, is just making sure that we can continue to improve performance against the 3 new modern cancer standards. So the faster diagnosis of cancer, where patients get a diagnosis or exclusion of cancer, importantly, within 1 to 28 days, and then the new 31-day and 62-day standards. So there are now 3. The faster diagnosis standard we are meeting nationally, and we've done particularly well in RM partners. We'll come on to that. But obviously it's very important for patients that we continue to improve the performance against, and that threshold will increase to 80% by March 26. So trying to improve performance for people, we're going in the right direction, more to do on the 31 and 62-day standards, sort of nationally. Susan and Lucy will talk about locally. And then another very important part that I've touched on is closing the sort of deprivation gap. We know that level of social deprivation is the biggest determinant of someone's outcome from cancer treatment, and we can still see quite a lot of inequity in access and delivery and then outcomes in our patch. So closing that deprivation gap is a key feature which you'll see in the proposed strategy going forward. And then the third thing in cancer is just our ability to really transform the way we're working with patients, and the role of things like cancer genomic medicine, which is increasing and transforming care and precision diagnostics and managing recurrence much more accurately than we've been able to do before. So the standards, the deprivation level, tackling inequity, and then thinking about transformation are a really important part of what we're trying to do here. Whoops. So the Cancer Alliance, I think before we had an RM Partners cancer strategy, I think it's fair to say every cancer organisation in our patch had their own plan. So what we've actually really done consistently well, I think, is bring together a single plan for both the ICBs in South West and North West, with some distinctive sort of things that we have actually delivered, and then a set of priorities about where we have to go from here. And as I said, as everybody knows, when patients have cancer, they travel through many parts of the health system, from community, primary, secondary, tertiary care and back through, often many times, and it's very important we make that journey as easy and seamless as possible, with sort of fast response at each point in that patient journey. The cancer strategy we've had until now, so we had a previous one from 2021 to 25. There was a particular emphasis on early diagnosis because that's associated with significant survival benefit, and I'm sure Susan will come on to some of the achievements in that regard. But I just tell you that sort of early diagnosis rates across the country were static for about a decade, and just beginning to see that shifting through the work of RM Partners with all the partners involved. It has been fantastic and really important for patient survival. So we had 7 work programmes to deliver the strategy. It sort of feels like going back in time a bit, but we had a lot of work to do post-COVID, quite honestly. I think, a lot of patients didn't come forward. We saw a dip in patients coming forward. We had a sort of dip in early diagnosis rates. So it was really important that we recovered from that, and that was done, I think, successfully, but Susan will come on to that in a bit more detail. We've also focused on variation in things like screening programmes and trying to increase uptake. I mean, the whole thing is about making it easy for people to come forward and giving them the best possible experience of care. And then working with PLACE and PCN partners to diagnose cancer earlier. So there are specific programmes like the lung checks that we referred to earlier in the Part 1 meeting, but a range of initiatives being undertaken with PLACE and PCN partners to really encourage people to come forward. And then, for some of us, it's also about trying to improve those diagnostic and treatment pathways, and not attending not only to the sort of technical aspect of care, but very importantly for patients, the personalisation of care that fits their needs as an individual and fits their particular kind of cancer type as well. So I think that's all I wanted to say as sort of context, but this is here today for your comment and approval. So it's here for discussion, comment, and then hopefully approval, so we can move forward and carry on delivering for patients across the whole of West London. But I think, Susan, you're going to say where we've got to so far, level of achievement, and then Lucy will do the look forward on the strategy.
Thanks, Callie. So, as Callie said, at the absolute heart of our previous strategy was early diagnosis, because it's the most expedient way to save more lives from cancer. RM Partners started in 2018 with a baseline percentage of early diagnosis of 56%. We're now really proud that the data that we're seeing now shows that we're about 60%. And that's one of the only cancer alliances to have made that change. And looking under that data, what we're seeing is 4 pathways really driving that. Lower GI, where FIT testing in both the symptomatic and screening pathway has been seen as much more acceptable to patients and really improved engagement with the screening programs. Prostate cancer, where this was an area we were really concerned about post-COVID and did a huge amount of community outreach, working with both patients and GPs to really get some improvement around prostate cancer. And some of you will remember the Man Van, which was part of that. That's really been echoed by some of the national Comes From Prostate UK there. Gynecology, where I think the wider awareness of women's health has really increased volumes in both routine and urgent cancer referrals. And I think as a result, we're seeing slightly earlier diagnosis. And then the other one was lung, where we had implemented through RM Partners a lung nodule screening programme, which is where somebody had symptoms that were seen incidentally, and we kept an eye on those patients, and that meant we were diagnosing people earlier. That's a really big win, because it means that even before we've started the large-scale rollout of improvements in lung cancer through the Targeted Lung Programme, we have already got an improvement in lung cancer. As Callie mentioned, COVID really impacted on all of our constitutional standards performance, and I think that for the cancer standards, they're important not just for the fact they're constitutional standards and something we're obliged to provide as part of our contract with the public, but also because for cancer, it's really important that you start treatment quickly. One of the things that I think is really worth noting is just the volume of additional activity since COVID. In South West London, there's 24% more urgent cancer diagnoses or referrals since 2019-20. And these are the most intensive ones for an outpatient because they require so much extra diagnostic capacity. And that's really been absorbed by providers working really hard and working with our providers to understand how we can provide more intelligent workforce models that really help people work to top of licence. For treatment, we've had 15% more patients on either the first or subsequent treatment pathway, and again, that's a significant amount of extra activity. So with those two things in mind, we're really proud of our providers. We haven't got any of our providers in tiering, which is actually one of only 2 ICSs in London. The other one is North West London, who also are part of RM Partners. But we also have delivered the constitutional FDS standard of 77%. As a CCG, and are confident all of our providers will be at that level and sustaining it by April. The 31-day standard, we again have been delivering. Again, we're one of the only ones in the country to deliver that. The 62-day standard continues to be a really difficult one for our providers. It's the one that got absolutely hit the most through COVID. And so if I say that nationally we're sitting at a 70% target, you'll understand how big the achievement is in South West London to be at 79% in September. That still requires an awful lot of work. We are aiming to deliver 85% because it really reduces the amount of duplication in the health service. It's much, much better for patients, and it really means that we've got resilience within our cancer pathways. So, as Callie mentioned, inequity is a significant issue, unfortunately, in cancer as well as other health pathways. And this is something we've been really working very, very hard with, mirroring some of the approaches that South West London have trialled in terms of working with communities. Over the summer, our new Patient and Community Engagement Forum helped us to shape a big summer fund where we had 120 grassroots organisations across North and South West London delivering over 200 events on cancer awareness. And we gave them training to make sure that those messages were really consistent and accurate. That's something that we're continuing to work on and using more and more as a vehicle to make sure that people understand and are able to co-design our services. In terms of screening, we signed our at-scale contract to deliver targeted lung health checks last year, and have been working with our tertiary and DGH providers to make sure that there's a really good pathway once people have come off of screening and need to have more active investigations. That means that we're expecting to see an improvement in terms of the gap for deprivation by stage, because we know that unfortunately smoking is so linked to deprivation, and so by really focusing on lung cancer screening we expect to improve that. For the other two cancer screening, bowel and cervical, both of which are national, we've partnered with the ICS population health team, and this is the first area we're focusing on. And what we're really able to now see in real time is which boroughs are less likely to have screening, which demographics, age groups and GP practices. We've had screening facilitators for all of our screening programmes working with primary care for the last 5 years, and we also now are supporting work particularly for deprived people. We know that for cervical and bowel screening, deprived and people with an Asian background are less likely to have their screening. For women, younger women are very unlikely to have their cervical screening, and men are less likely to have bowel screening. And so with those, what we're doing is now much more focused campaigns to support those groups. For cervical screening, we know self-sampling will be probably the biggest win, and we're working with the London team to see if we can actually go earlier than the national team to get that, because we think in London it will actually provide a step change in coverage. We know that deprivation is probably the biggest risk on a cancer pathway outside the actual disease. It means that people are less likely to come forward, they're less likely to have screening. It also means they're less likely to be diagnosed with an earlier stage disease, and obviously that affects mortality. So Lucy will talk through how we're approaching these issues in our new strategy moving forward. Thank you.
Thank you, Susan. Thank you, Callie. Can everybody hear me? Lovely. So my job is to talk you through what we're hoping to do over the next 5 years, so from 2025 to 2030 as the cancer strategy, and we're hoping that you'll adopt it as your cancer strategy and support the approach. What I'm going to present today is fairly high level, but some of the work programmes are all in the appendix. So if there's this question around how we're actually going to do it, I hope that you will have all of that information for you. So I think the real aim for the next 5 years is that we want to have a very focused but very ambitious cancer strategy for the Alliance, where we can really start to see step change at scale. As Callie and Susan have already mentioned, I think our real priorities is around trying to realise a reduction in the variation and inequality that we still see in every part really of our cancer care. Obviously, we've been mindful when we've been putting this strategy together to make sure that it aligns with both ICS priorities and the strategic approach, but that it's also mapping to the emerging priorities from the NHS 10-year plan. Certainly in terms of those principles of what we think is going to be happening with the NHS long-term plan, it's all around moving to prevention rather than treatment, trying to get care out into the communities, and moving from analogue to digital. So those will all be underpinning part of our work streams. As you'll see in some of the slides that we circulated, we have some guiding principles, and I think the reason why we put them here is to really emphasise that these guiding principles are going to be key in our strategy, and they've all been developed through really close working with our communities and listening to what is important to them and how they need their care to be delivered. Susan's already mentioned that we have a strategic forum which is built and has representation from all of our local communities, and we work with them in a continuous way, and they're fed into what we have developed into this current strategy. We also have a good track record, I think, of working with our communities, and that's something that we really want to continue to do. So I hope that you've all got the kind of pictorial summary of the ambition and work programmes for the next 5 years. So as you'll see over the top, we've got our kind of strap line of wanting to save more lives by enhancing prevention, improving early diagnosis and access to timely and personalised treatment, supported by our overarching commitment to eliminating variation and reducing inequality. There are 4 main strategic work programmes: prevention and screening, early diagnosis, reducing time from referral to treatment, and treatment care and survival. Importantly, there are some cross-cutting themes at the bottom of the page, and these are essentially our enablers, and they will be present within every individual piece of work that we're doing. So it's really making sure that whatever we're doing is data-driven, that it feeds into our equity and co-design, that it's sustainable, and that we have an eye on workforce, technology and AI, and that we are innovative and want to spread and adopt our good ideas. Just moving on to, or focusing particularly on the prevention and screening, this is the first time as an alliance that we've had this as a standalone work programme. Historically, our focus has really been on people with an established diagnosis of cancer, but I think it's clear that we have to have much greater focus on stopping people developing cancer in the first instance, and also as identifying people at highest risk of cancer, and having much greater awareness and ability to support that group. As it says in the slides, we think that about 38% of our cancers are preventable, so to not have this as one of our priorities, I think, would really be a miss. In terms of prevention and screening, we've really focused on 2 bits that we think that we can probably have some level of influence on. One of which is vaccine uptake, so in particular HPV vaccination. We know that there's massive variation across our boroughs, and many of them are below the national target. And there are certain populations that we know are particularly at risk of not uptaking that first vaccine invitation. The real win of HPV vaccination is that it potentially has prevention for 4 different tumour groups. So head and neck, cervical, genital and anal. So the wins here are massive, and it's a fairly low input intervention at a good age to do it. Along with that, we're thinking about how we can support tobacco cessation. Obviously, there's been lots of focus on smoking. We know that smoking is much more common in deprived groups. And when we try to think about how we can do this, it's going to be really, again, around trying to select our highest risk groups. So we've got good rollout of the targeted lung health checks. We know that that group is particularly high risk of developing cancer. They've smoked or are current smokers by definition, and we're really hoping to achieve an 80% to 90% quit rate in that group by making sure that we have equitable access to high quality care. Moving on to early diagnosis, I suppose the strap line is that we want about 65% of cancers to be diagnosed by stage 1 and stage 2. The way that we hope to achieve that is firstly by focusing on the patient interval, which is when people are starting to develop symptoms or signs of cancer, that they firstly know about them and that they have some symptom awareness, but secondly that they have the trust in the system to come forward. So through engagement with our community groups and our primary care services, we're really hoping to firstly improve symptom awareness, particularly among for tumour groups that we know have late presentation, but also enable people to come forward and get the help that they need. The second part of the early diagnosis programme is around the referral interval, so how long it is taking a primary care clinician to refer from the point of presentation. Unfortunately, we know that there's huge variation in what is currently happening at the moment, with certain groups having to present 3-4 more times before they're referred and having significant delays in their diagnosis as a result. Obviously, this has huge impacts on them in terms of their outcome from treatment and even survival. The work that we're doing here is focused around the early diagnosis extended contract, where rather than having this fairly broad brush universal approach, actually borough by borough, based on focusing initially on the boroughs with the worst early diagnosis rates, we're doing a very focused piece of work with all practices within that specific borough to enable them to do case review, because we know that that's a really, really powerful learning marker and something that genuinely does change the way that we practice. Working about ways that they can engage with their local community groups that they know that they probably have difficulty in terms of serving. increasing access to education and interface with primary and secondary care colleagues, because we know that that really does smooth out somebody's experience of cancer diagnosis and subsequent care.
So Lucy, please pause for a moment. This will be over shortly.
Perfect. That took me to the end of early diagnosis. It's perfect. So the third strategic work programme is around reducing time from diagnosis to treatment. We've always had, I suppose historically what we've said is, what is the time from referral to diagnosis? And actually the thing that really, really matters for patients is getting treatment. So we internally are really making sure that that is the thing that we're focusing on. We were speaking only a little while ago and saying that actually excluding cancer is fairly easy. Diagnosing it is really difficult and can sometimes be timely or time consuming, particularly with more complex diagnostics. So really the focus here is going to be around really striving to meet the constitutional standards, working with our providers to make sure that diagnostics and things are streamlined, and really thinking about system working and reducing variation amongst our trusts. So that's that strategic work programme. And then finally, moving on to treatment, care and survival. This is really around not only survival, but also quality of life for our population. And I mean, we're doing some work around things like international benchmarking that we're hoping to make a much more standard approach for us in order to compare our care with what we're achieving and what's being achieved internationally, to really make sure that we're holding ourselves to account and that we are genuinely delivering the best care according to kind of world standards. In addition to that, I think there's also going to be real focus in terms of how care can, or where care is provided, and how that can transform patient experience whilst remaining in line with best practice, so that real interface between hospital and communities. And then in terms of personalised care, really striving to ensure that it remains holistic and patient-centred, and that the experience, even if it's not a favourable outcome, is a favourable experience for our population. And we've got particular focus on parts of the pathway that we know have been chronically underserved, although there's recognition that they're a huge issue. So things like cancer-related anxiety, sleep disturbance and access to specialist pain clinics. So we have selected bits that we know would really transform a patient's experience, and are hoping to really start to drive forward some step change in those services. So that was a quick run through, but as I say, the kind of how is detailed in your packs, and I'll hand over to Susan to close.
Thank you. So I think in summary, the cancer strategy builds on what we've achieved before, but addresses some of the areas where we don't think we've made sufficient progress. I think at the absolute heart of that is really partnership working, and it's really good to see all of our partners here today from both primary and secondary care. I think what that means with the might of all of that partnership and collaboration is actually we can go further than, and we should be as a London ICS, better than everywhere else really in the country. Thank you.
Callie, thank you so much. Susan and Lucy, thank you. Really, really helpful presentation. I think, you know, if we look at Cancer Alliances and the fact that they reach across sectors, they're part of primary, secondary and tertiary care, and they bring in our partnership with our local authority colleagues and with the voluntary sector, it actually feels like they're actually living, breathing examples of what we're trying to do as an integrated care board more generally. The really active partnerships. I think we can be really proud of the work that RMP has done since 2018. I think there is a strong record of success. I think the last few years have been particularly impressive with the focus around the health inequalities agenda. I think the work done on targeted lung checks has been amazing. We know the outcomes of that, both in terms of lung cancer, but other cancers identified in the process, which has just sort of been amazing. Similarly, the prostate cancer work, particularly with black men, has been absolutely exemplary. Really good to see FIT being rolled out. Certainly, Matthew may want to say something. on the basis that Croydon, of course, was one of the key places where we tested the FIT technology and its and the public's willingness to engage with that particular process. So I'm really pleased that we had, I think, something like 2,000 people in Croydon in the early pilot stage for that, which was really important in terms of getting it right. There are some specific Cancer Alliance outcomes which were established when you were established in 2018, national outcomes. I think they're sort of implied in all of this, but it may be useful to just, if anybody can recall them, I can't quite recall what they are. I know one of them was very much about shifting, I think it was a percentage shift into earlier diagnosis of type 1, type 2, etc. But it might be useful referencing those, not necessarily now, but moving forward. A couple of other things. I think, we've got 14 metrics in this report. You're asking us to sign off this strategy for the next 5 years. I'll get my views of my colleagues, but my assumption is that we will, because I think it's a really sound strategy. What I would be asking is that we can have this coming back to the board on an annual basis, particularly reporting on those 14 metrics that are within the report, and where we can, breaking those, and where appropriate, breaking those down by gender, race, and deprivation as well. As I say, where possible and where it's relevant for those particular metrics. Can I take some other comments from colleagues? Maybe primary care would like to come in. So, Nicola.
I would, thank you. Thanks very much. I absolutely endorse the approach that you're taking, and I think it's really, clearly set out, and I welcome it. And I know that RMP is viewed very positively by our primary care community. You do a lot of work and infiltrate all over, and it's really, really good what you do. And I suppose I've got a reflection more on us for a board, really, when we're thinking about how these big strategies, because we have big cancer, big urgent care strategies, we've got something coming on immunisations, we've got lots of things that have, this is a cumulative impact on primary care, and how important it is that our primary care is able to, really deliver on all of this. And particularly on the kind of early intervention, because some of the ways that we work, so, the way that we work now can really impact on the delivery of what you're trying to do here. So more episodic care, more real transactional care, more care by health professionals who are non-medical, more virtual care. We're about to do the digital strategy. All of those things really impact on our ability to pick stuff up early. And I think we just need to remember how much we rely on general practice, the wider primary care, and the work that we all do in our communities to kind of deliver all of that. But full stop, and I really, really support this.
Thank you, Nicola. I mean, we were talking earlier about the 3 shifts, and this feels like it embodies all 3 of those shifts within it, as well as actually keeping a really strong place for tertiary and acute care. Talking of acute care, I'm going to go to Matthew, then I'll go to Vanessa, then to John.
Thanks, Mike. And thanks, colleagues, for a great update and obviously lots of support from ourselves. You asked a question about the fit testing. I would reflect on it. I remember sitting in the first conversation we had with the primary care colleagues in Croydon who were quite nervous about what the impact of that would be. So it's not straightforward, some of this, but I think through good collaborative working, we found a way through that, and that's now a successful aspect of the process, and obviously is having some beneficial impact. So I think that's a good demonstration of how you can do these things, because they're not straightforward, and I've put a lot of store behind the work that the partnership has done on this. That's an example, but there are many others. Certainly the work more recently we've been doing on faster diagnosis standard, from a Croydon perspective, that's something that we've had to work really hard at, but I actually think over the last year we've really made positive moves again. Thanks to Susan and the team at RMP, who have massively helped us with that, as well as the hard work of folks on the ground. So, an massively important agenda, and I agree with you, it's very much in the spirit of the way that the service wants to move. So I think that's a good thing.
And thank you for referencing Thank you for referencing the FIT and the role of primary care in testing that. I think it loops back to our earlier conversation about making sure that part of our response to the 10-year plan is encouraging further research in primary care. And that programme would not have been possible if primary care had not participated fully in that, and we learnt the lessons from what worked really well and what was slightly more problematic. Vanessa.
Oh, so I echo what everyone said. It's an excellent document. I understand it, so that's a good part. But obviously the psychological impacts of cancer are really significant, aren't they? And at the moment, I think what may happen if someone's had treatment is they get really good psychological support during that treatment. If they get better, they get discharged back to their GP. Their GP then refers them to mental health, and we bounce. And rather than doing that, I think it would be useful as a system if we could think, particularly for those people with perhaps more complex psychological needs, how we stop the bounce between the three of us effectively, and we support that transition arrangement. If there was work that we could do together, I'd be really keen for us to do that.
Thank you, Vanessa. I think that's really, really helpful offer as well. John, this is sort of part of this is a prelude to your immunisations piece, but you might want to pick up on HPV in this section or in the next agenda item.
Yes, it's all nicely linked. Who would have thought, Mike? I'm just going to actually go back to fit testing and a personal experience, and an example of how the NHS can get things right. So if we take fit testing, it's a great innovation. It brings health benefits to those who are eligible for screening. But by combining it with the NHS app, we can actually make it a seamless service where we don't need to increase capacity, dare I say it, in primary care and give them yet another task. So in my case, through the app, I received a nice message saying parcel would be arriving in the post. Please open it and do what I was told. A week later, a parcel duly arrived with the kit in it. It sat in my locker for a little while because I'm a man. That's what men do. We've talked about men's reticence when it comes to screening. I received a very polite message in NHS app a couple of weeks later from the partners in the surgery suggesting I really should take the kit out of the locker and just get on with it, which I duly did without them needing to send the heavies round. And finally, 2 weeks later after posting it, I get a message back in the NHS app saying everything is hunky-dory. So if we can take that approach to all forms of immunisation and screening across the NHS, it'd be fantastic, and it's one of the reasons why we need to get on board with the NHS app, accepting for the fact that the app won't be available and won't be suitable for everyone within our community, but that then gives us opportunities to manually support those people through old techniques like letters and phone calls and visits, and we use the technology for the rest of us who can benefit from it from as long as we can.
Thank you, John. That was a really good example of how we can utilise our technology. That might be a conversation you want to have with some of our colleagues nationally when we start talking about cervical screening and linking that with the range of other technologies we have, which doesn't seem to be one of their priorities at present, sadly. Sarah.
Just wanted to reinforce how well I think the small grants program worked. We had 63 organizations, small grassroots organizations in Southwest London that were successful with the program, and they were going from Korean, weren't they, to Asian, to groups working with carers, groups working with residents with learning disabilities. So really reaching out to those communities affected by health inequalities. So I was quite happy to see mentioned in your guiding principles, and hopefully, will continue. I also had a question about your providers collaborative and how your RM people and communities strategic forum will link in, because I know you were kind of planning how to make sure that that forum that brings in quite a lot of voluntary sector groups then links in into your providers collaborative.
Thank you. So part of the way that we've designed things is to make sure that the community and patient forum works both with the communities but also has a seat at the table for our governance. And so representatives from the communities forum also are in all of the RMP formal governance forums, meaning that the information is two-way, and also that their input is across all of the things we do. In terms of working with providers, we're doing we've done a pilot with one of our other trusts in North West London that's really about how we fundamentally use the feedback of people on treatment to change the way we deliver things. And pending the outcome of that will be a way that we probably do that at trust level using the existing groups, because most of the hospitals have got good cancer groups going, and we really want to harness those, because then it gets very, very into a place-based and local issues. Does that answer? Yeah.
Thank you for that. That's really helpful to know. I really like the way in which you're looking at how you can enhance the feedback to improve services. Jonathan.
Thank you very much. It ages me somewhat to think back to it was 2018 when we started on this journey, so thank you for reminding us of that, Callie. I sort of wanted to, I think it's been reflected in the other comments, but I just wanted to call out our MP for managing to keep the show on the road after the impact of COVID on cancer patients and all those missed diagnoses of patients, finding them, and then making the progress that we've seen around early diagnosis, around prevention, around inequalities, all the things that others have called out. That's the real skill and art, and there's probably learning for other provider collaboratives locally and nationally actually from that. So I think maybe how we distill that's important. The specific comment I just wanted to make was around prevention and screening, and how really pleased I was to see that as a core part of the strategy. It's the heart of what an ICB should be about. There are particular areas where we do need to focus in that space, and we all, I think, all recognise that. So really keen to see that, and really keen for the ICB to work closely with our MP to make a difference in that space, because it's things that we can often do quite cheaply, as you pointed out too. So thank you.
Thank you, Jonathan. Mercy.
Yeah, I welcome this. This is really comprehensive and good. And one of the things I always noted on the Quality Performance Oversight Committee is that there's usually quite good news on the cancer front, which is kind of heartening really compared to some of the other areas we struggle with. I just wanted to ask about the international benchmarking, because obviously it's, where we see the UK and where we see international stuff. This is great and really ambitious and really getting to the heart of some of the, especially the inequalities stuff that I've seen for at least 30 years, and some of the same issues come up time again. Not just awareness amongst communities, but also that sometimes they do go back and are not really taken that seriously. So I'm glad that that's being addressed too. So yeah, maybe just a little bit more about the international benchmarking.
Thank you. So there's an international benchmarking comprised of 10 matched countries. So they're organisations with countries, with similar healthcare systems to the UK. So Australia, Canada, not America, because it's completely different. And the UK, whenever you see things in the paper about the UK cancer outcomes, it tends to be based on that data, which shows that our outcomes are less good than the international. This is a really complex piece of work to do, and I think our view in RM Partners is we have 3 of the biggest tertiary centres in the country within RM Partners, and we should be pitching to that as our aim, not just sort of top of the UK. We're starting with 3 tumours where we think we can do better, where we're not even top UK, so esophageal cancer, endometrial cancer, and lower GI, urology cancers as well, bladder cancer. And the reasons why we're focusing on them is that we haven't got the outcomes we want at the moment, and they're quite discrete in terms of being able to actually create a model for development. What we know is that some of it will be stage differences. People come forward later, and some of the work that we're doing with the CDCs will improve that, because we know that the more access for primary care to imaging, the earlier cancer stage diagnosis. That's really come from Australia evidence. But what we will be doing with the in-treatment piece is looking at really note by note to understand the variations in care. So it will be at patient level audit, because probably the differences are subtle but add up to a big problem. So the standards of care between NICE, which is the best internationally are no different to Australia. It's just how they're implemented and the way we're doing it. And so that's the work we're doing, but it is very careful. It will not be a quick win, but I will hope to have something by next year, Mike.
That's brilliant. That can be part of next year's report back. Perfect. I'll take Karen, then Jamal, then I'll go. We'll need to close this. So I'll go to Sarah for final comments from the floor, and then Callie for any wrapping up that you might want to do.
Thank you, Chair. And just to echo what everybody has said so far, really, really welcome this. But also really welcome the fact that RMP are in our patch and the care that you provide to patients. So thank you for that. I suppose my question, the thing I'm pondering is there an additional ask? So if we wanted to make saving more lives through cancer the job of everybody in the in the partnership, and I'm talking about not just the NHS at this point, obviously the local authorities, etc. If we wanted to give that to everyone as a responsibility or a job, is there something else that we would be seeing here that you haven't said? So is there a kind of an additional ask, I think, from the system and what the system can do to support?
So I guess RMP is really only as good as its providers, and we're really lucky about the commitment we have. RMP did not improve the performance without a huge amount of work on the ground from each of the trusts in actually doing it and listening and actually having to take tough decisions to prioritise those patients. So, and I think that's similarly true in primary care. So I think in some ways we have a lot of consensus that cancer is everyone's job. I think probably the difference with this strategy is the interface we need with local authorities. Tobacco cessation sits with them, as does HPV vaccination, and that's something we're beginning to do. And I think what we have for HPV, as Lucy says, we haven't got any borough and RM partners that's above the 90% requirement. And so that means that we actually need to do some things at scale, not just borough by borough, to try and get a bit of a step change. So I think that's the bigger change. Thank you.
And we might come back to that HPV issue and what else we can do in the next item. Jamal.
Thank you, Chair. It's a really good report and some really good successes, so thank you for sharing those. Just two quick questions, if I can. You mentioned that it's the only alliance to make the shift from 56 to 60%. I just wondered if there was any learns for other alliances in terms of one or two nuggets that you would have for them if they were listening in on this report. And then just the other one in terms of, I think the underpinning this strategy, a lot of it is around personalised treatment, genomics, early diagnosis screening, just new technologies. I just wondered how you're set up for that in terms of leveraging the opportunity. It kind of builds on Karen's question, which is any support you need from the system to help with that, particularly with the 10-year plan on analogue to digital.
So in terms of the things that we're doing with early diagnosis, I think our feeling is that the work we're doing with primary care, which has started already in Croydon and based on a year's worth of research and fact-finding in partnership with primary care, will be something that will help other alliances as well as ourselves. I think we're pretty good at borrowing and spreading as a set of cancer alliances. So Callie's national team is very good at doing that. And for instance, we've put in the breast pain model that's really based on Derby. So I think we do quite well there. In terms of new technology, we know that AI will transform all diagnostics and probably a lot of the treatments, the radiotherapy planning. And I think one of the things that we want to do is make sure that the NHS pound is used very judiciously there. So we've partnered with NICE, myself and the Chief Executive of NICE have put together a joint post that will work from NICE but with the Cancer Alliance and actually all of the trusts who've got big AI pieces to make sure that we're really focusing on their emergent EVA assessments to make sure that we're quickly getting the evidence we need, dropping things that don't work and focusing on the things that do.
Great, thank you. Sarah.
So firstly, thank you very much for the report and thank you very much for the work that's going on in RMP. I was actually reflecting on, because I was here before 2018 and how things have changed. And I do think that one of the key ingredients of RMP RMP being successful is the ability to engage across the system and work with everyone. And I remember pre-18 when actually that wasn't the case. And I used to hear quite a lot, actually, particularly from primary care, around how they didn't feel engaged, they didn't feel part of the process and the partnership. So I think that's really important. I think that's a real positive for RMP. And I often bask in the reflected glory of RMP when we get our cancer figures that come through and show us to be one of the best in the country. And then on the other flip side, what I would say is, but we still miss people and we still have a problem around cancer identification. So I'm really, really pleased as part of this to see this ambition around top decile internationally, because nationally we don't do as well as we could on cancer. I'm sure that Callie would, echo this. So nationally in the UK, we do not do as well as we should on cancer. And therefore because we are one of the best, we ought to have this ambition to be internationally one of the best, because we are still letting people down whether we like it or not. So really, really positive. So it's a really positive piece, really pleased to see it, but extremely pleased to see this kind of ambition that we should have for our local residents. So thank you very much.
Callie, over to you for final words.
Thanks very much, and thank you to everyone for their support, and especially to Lucy and Susan for presenting, and the team at RMP, who I think, we can show very distinct achievements. So I think it's important in supporting this next strategy that we come back with an annual review of how we're doing. I'm really happy to do that. I think there's so much opportunity in cancer because this is a long and well-established group. Susan also, she didn't quite say it, but she also leads a National Cancer Alliance Forum. So there is a share and learn, and you gave the breast pain example of changing a pathway, but there's a fantastic national share and learn between the alliances about who's doing what, rather than everyone inventing their own. It's all about sort of precision risk stratification, so a lot of what we're doing should be good for patients and actually good for NHS productivity, so it can do the two jobs together, if you like, in cancer. So I think that's important. The key thing that I see around the country, and it's really important for the ICB, is that the ICB supports the Alliance. In some areas of the country, the sort of cancer transformation money gets diverted and is used not for cancer, if I can put it that way. So I think, thank you to ICB colleagues for supporting the work of RMP, the team, and particularly allowing us to deliver that improvement for patients across the whole patch. So we'll come back with an annual report. I'm taking it that there's approval for the next strategy, and hopefully we'll be able to give some good feedback in 12 months' time as we work through all these initiatives. Focus is all, isn't it, to make sure we deliver.
Absolutely fantastic. Thank you, Callie. Thank you, Lucy and Sarah. Susan, rather. Sorry, that's Sarah. I have heard no dissent, so we are approving this strategy for the next 5 years. Please, if it hasn't gone yet to North West London, tell them that we approved it and we highly commended it to them.
Thank you very much.
Thank you. We're going to move on to immunisations, and we're going to be joined by Sarah. So Sarah Copeland, when there's some seats at the front, do you want to come and join the main table? Because I think you're going to be part of a double act with John. So a big welcome, Sarah. Sandra, sorry. I've got Sarah on my mind, haven't I? Apologies, Sandra. Everyone's Sarah today. My colleagues over here, Sarah. Okay, we'll move on to this. John, I will hand over to you on this issue. We've already flagged up how important it is in terms of HPV when we were talking about prevention earlier in the Part 1 meeting, Part 2 meeting rather. IMS and VAX was a clear priority for us. So over to you, John.
Thank you, Chair. So it's how do you follow an act like RMP? So somebody has to go next, so it's going to be me. So in preparing this paper and conversation for the board today, I was forced to reflect back 27 years to my days as a junior doctor. And the last time I had to talk about the whole range of vaccines and details was down at a Royal College examination diploma in child health in a very large room with 4 very earnest and august people sitting at the top of the table, which brings me back to today. And very eminent and very knowledgeable people. So it's a case of deja vu 27 years later. But in those days, it was a wood-panelled room, and you had to go in your own. So you couldn't bring any friends with you, or experts, as I would like to call them, because back in 1997, vaccinations was pretty simple stuff. You had mumps, measles, and rubella. You had diphtheria, tetanus, pertussis, and you had oral polio. To pass, you just needed to know at what intervals you gave them. And the honours question was if you remembered that you gave flu to old people. And that was pretty much vaccines back in 1997. So we roll forward to 2024, and we have over 23 vaccines which we now give to people across a whole life cycle. And it has exploded in terms of the medical science, and all of these vaccines give great benefit. However, we have challenges around vaccines, and I'll come to the reasons why, but if you just allow me to tell a second anecdote. So in 1997, back in the day, I was an army doctor. It was brilliant being in the army. People tended to do what they were told, even me. We hadn't discovered the values of democracy or personal agency, so if you were told to have your vaccine, you tended to do it. If, like Private Kershaw, you demurred a little bit, Staff Sergeant or Colour Sergeant Clancy would show up, and you'd see the error of your ways and you'd get vaccinated. And normally in my battalion, we had a vaccination rate of 99%. The 1% had gone AWOL, but we were confident that the regimental police would track them down and bring them back, and we would get to 100%. So it was a little bit of a culture shock to me to leave the army in 2002 and become an NHS general practitioner. And to discover it didn't quite work in the same way when it came to immunisations. At that stage, myself and my wife, our first child had arrived, and it was our turn to vaccinate our child, Alice, with mumps, measles, rubella. You might remember at the turn of the century, a certain Andrew Wakefield, who was allegedly a doctor, brought a huge scare into the public space around the false link between autism and mumps, measles, rubella. And I doubt there's anyone in this room who had children at the time who had them vaccinated wouldn't have been concerned whether you had a healthcare background or not. And we did have a healthcare background, and I'd be lying if I said we didn't go to our GP surgery and wonder if even us, people who knew the science, were worried about actually giving MMR to our vaccine. So that was the context in 2002. So vaccine hesitancy, vaccine scares, and all of that sort of stuff existed back in 2000, and it had existed long before the internet and long before some of the trolls came along. So some things change and some things don't. But those sort of three little anecdotes sort of bring me around to the complexities of immunisation and vaccinations. And the world has moved on, and it is an awful lot more difficult. And to oversee a successful vaccine programme unfortunately isn't like a Delia Smith recipe. It's a bit more Heston Blumenthal and very, very complex. And we have a set of figures in front of us today which shows us that while South West London might be doing pretty well compared to other areas in London, when it comes to the national picture and national benchmarking, our vaccinations are not where we'd want them to be. Now, this picture isn't a new picture. It hasn't developed overnight, and it's related to some of the challenges and some of the joys that are hard living in London, where we have a mobile community, we have diversity. All those things that we cherish actually sometimes in some ways make it more difficult to get to the rates that you would want. So there's a whole load of reasons why we're not where we want to. I'd be slightly dishonest if I wasn't to say I'd be anxious about not just maintaining these rates, let alone improving them over the next 5 years, because I kind of think it's going to get increasingly difficult to keep people with us on the vaccination and immunisation journey, which is why I've come along today with Sandra Copeland and with Charlotte Gwan to talk about an element of our approach in South West London to the vaccination and immunisation challenge, because we've kind of thought that it doesn't matter how much communications we throw out there, how many clinics we lay on, how many people or vaccinators we have, how much we use technology. The reality is we're trying to bring our local communities and citizens with us in an age where different communities for different reasons have different attitudes to vaccinations and immunisations. And while there is a link to deprivation, I can assure you it's not just a deprivation issue. So in the paper, what I do is we touch on everyone loves a strategy. So we have a national strategy. We have a London strategy. I decided we wouldn't have a South West London strategy. We would try and come up with a delivery plan. And our delivery plan pays attention and heed to those two national and regional strategies in terms of delivery. And a key point of that is about how we use engagement with our communities going forward. You'll see a slide in the deck which relates to childhood immunisations and the scores on the doors in South West London where we're doing well and not so well. I would always caution you with the data that it's always kind of 6 months behind, and the reason some of the vaccine data won't be as good around MMR is because of the risk of oral polio 18 months ago. We had to do a catch-up campaign which delayed MMR2 for a reason compared to, so that was a London targeted vaccine programme. So you will see we have delivery plans which we've set out at South West London, and those delivery plans are delivered at place and governed at place, and we've just put a slide in there to discuss what the rates are or what the approach in the various places is and how we govern them. We've put some data in because everyone talks about flu vaccine and everyone talks about COVID vaccine. We are where we are. We've seen a drop-off of uptake in flu and COVID vaccine right across the country. We're doing better in South West London, but that doesn't necessarily reassure me that we are where we need to be, which is why I'll come back to what our approach is going to be going forward, or more of our approach going forward. We put in some data on healthcare workers. It is now 3 weeks out of date. Happy to update the board on where we think we are with healthcare workers on our most recent data, but any of our chief exec colleagues in the room will be looking at their healthcare worker data, and they will know and understand some of the challenges around encouraging our colleagues to get vaccinated. And myself and Elaine agree strongly on this, is that we work in healthcare. It's an industry which is a risky industry. Safety should be our top priority, and we think being immunised as clinicians in the NHS is one of the things we should be doing from a professional and a vocational view. But we may hold that view, but actually persuading everybody else from a professional perspective that's what they need to do has proved to be challenging, particularly as vaccine hesitancy, if not fatigue, has set in after COVID. So that's basically the key data which we've got on the slide deck. I think there's a little bit of everything in there for everyone. We've talked about some of the innovation stuff we're doing, particularly around vaccine hesitancy, making every vaccine count. We're mindful that our GP colleagues do some brilliant work in vaccination, but they are pressured like everybody else, which is why we're working closely with community pharmacies in terms of outreach schemes. So just trying to think slightly differently. How can we find the extra 1 or 2% in various communities and various outreach services, because every vaccine counts. I'm on record as being anxious about mumps, measles, rubella, having seen them as a junior doctor and have seen the effects on that. I think one of the problems we have is while the baby boomer generation might remember the impact of mumps, measles and rubella, it's something which has probably been lost on Generation X, Y, let alone Z or the millennials. So I'm kind of fearful that we'll need to learn the lessons of the past again in order to encourage people to come forward. I don't want us to get to that stage, which is why we need to keep working. So myself and Charlotte, we've always seen vaccinations through perhaps the lens of thinking about behaviours and cultural norms and values and how we engage with these communities. So rather than run through her 4 slides, I'll allow her to do that. And then I'm looking forward to hearing from Sandra, because actually Sandra epitomises our approach going forward of listening to our communities, and by listening to our communities, perhaps tapering our approach to how we go about vaccinating people going forward.
Thanks, John. So to return you to the slide deck, slide 17 is a good one to have a look at. So between 16 and 22, we're just talking about an overview of how we approach comms and engagement with our communities and how we support John's team to increase uptake. So I'd like to introduce Sandra, who runs the Togetherness Community Centre in Merton, and she's going to talk to us in a minute about our real community engagement and how that has an impact on the community she works with. But just quickly to give you an overview of the broader picture. So you'll see on slide 17, our approach is really data-driven, and it's really centred in community conversations, but not just community conversations. So we layer that community engagement with really geo-targeted information across all our digital channels in our low uptake areas. So actually targeting information by postcode, particularly using translations. And you'll see a slide 21, I think it is, when we talk about the results and the evaluation of those translated online materials and what traction we get with them. The other thing I suppose to say with all our partners in the rooms is it's really important to use our owned channels as well. So our partners really support our vaccinations and immunisation campaigns, because we know, don't we, that we all go to our local authority website and digital channels a lot more than our NHS ones, to be honest. So we've all got to find out when to put the bins out, how we pay the council tax. You know, I'm sure none of you have got parking fines, but if you did, you'd be all on the local authority websites. And having our information on vaccinations and immunisations on our partner channels to kind of really maximise the times that people see that information is really important. The other thing we've learnt, I think, through our comms and engagement is about keeping it local. So yes, we run national campaigns, but we have evaluated our work. When we talk about the place, the borough, and we use local clinicians to talk in video and in photographs, the traction with our communities and the engagement level goes up 2 or 3 times as much. So the local is so important. So you'll remember at the board a few months ago, we talked about our VCSE winter grants funding. That's why Sandra's here. And really it's about giving small pockets of money to really grassroots community groups who don't traditionally engage with our NHS. Sandra will talk to you in a second about this, but really we know that if John and I pitch up at community groups, you know, we are not going to have as good a conversation as if Sandra talks to the people that she knows and the people that trust her. So it's really about a good conversation rather than an instruction. So we have really changed the way we do things. So I'll hand over to Sandra just to talk about her experience last year and going into this year.
Okay, thank you for having me. So I am one of the programme coordinators at the Togetherness Community Centre in Mitcham. And on record, we have about 90 registered, 60 plus members, but a weekly average of about 35 to 40 attendees. And we run a series of varying activities, including chair-based yoga, chair-based exercises. And what we're really doing is looking at their holistic well-being to ensure that whatever we do is transferable back into their homes and keeping them well and safe. We have 2 groups, one that runs on a Monday, which is the Caribbean Social Club, and then we also have a Thursday group, which is an On the Move club, and it really is on the move because since we've started it, they've transitioned it into something else. And one of the things we try and promote is user-led initiatives within the group. So everything we do at the centre, we try to ensure that it's led by the members. So even in regards to some of the local initiatives that have been done around immunisation, we did the early detection of cancer immunisation workshop. We did the CHIS, the Childhood Immunisation Services programme. And we always try to ensure that we get from the users how they feel it will be most effective for them. And we also have used, this is our 2nd year, engaging with the Winter Warm programme. And we actually spoke to them about how the funding might be best useful for us to use for them rather than dictating how we were going to use it. And one of the things, and we're doing it for the 2nd year, one of the things we did last year, they said that they would like to have the funds to actually pay for their utilities at home. So what we do is we use the funding to provide lunch. Normally they pay for lunch themselves. So we use the funding to provide lunch. But what we did, we brought in someone from the debt management, counselling agencies, Age Concern to talk to them about how they can keep themselves warm at home otherwise. So it wasn't just the lunches they were getting other information. And that worked really well last year. And in fact, our attendance went up by about 11 all of a sudden as we were doing free lunches. And we do very culturally specific lunches for the group that we have. And what we do, we try to create a really relaxed and friendly atmosphere, because one of the things we find is that the generation that we're working with, which is the sort of Windrush generation, are very guarded about their information, whether it's medical or otherwise. But once they come and we make a general conversation of it in the group, because we will just ask general questions like, who's got any aches and pains since last week that you didn't have last week? Because it could, again, be the signs of something happening, and they just take it as another pain. They'll go out and get deep heat and rub it, and we'll be like, well, let's look at what could be causing that. And as a result of doing some of the programs, the early detection, we've had 2 people that's been diagnosed with cancer since, as a result of doing the program and then going and getting checked, because they then recognise that they did have symptoms. The thing with doing it locally is that we can help to demystify. We're not medics, but we can help to demystify the process for the users of the group. And what we will also do is support them when we signpost them on, because what we find is even when we signpost them on, as is recommended, they're not going. So sometimes we say to them, right, is there a family member you trust that we can talk to? Because what we don't want to do is take on all of that legwork. But we will actually talk to family members and say, look, we've spoken to your grandma, your aunt, and she's worried about going. Will you go with her? This is what we've done. And in addition to that, one of the things that came out when we did the childhood immunisation programme, Awareness Day, we discovered that 50% of our 60-plussers are carers for their grandchildren. So we gave them the information to give to their children who were working. And what we realise is that the people at work who are working during the days are sometimes the ones not accessing the services. It's not always the priority groups that we think. So what we've done is now we give information to the elders group and say, can you pass it on to your children, for your grandchildren, let them know if they want to come to the centre. So again, that's another way of reaching a group that I think was quite hidden before we did that session. So yeah, we are very happy with the Winter Warm Fund. It's not an exhaustive amount, but we try to make it stretch, and we actually use it to cover 7 weeks of activity, of lunch activity for the group. So that's where we are with that.
Sandra, thank you. That really makes it come alive for us. Thank you very, very much. Charlotte, are you and John wanting to say any more? No, you're fantastic. So we'll move on to discussion. Sarah, can I bring you in?
Sorry, I just wanted to add, it's £500, you know, 7 week of all this for £500 is fantastic value for money, and reach as well into the community is amazing, so thank you.
Yeah, I should have said thank you as well, actually, Sandra. Not just thank you for your presentation today, but actually for the work that you're doing in the community. Absolutely vital work. And it sounds like it's making a real difference to people's lives, which is actually what it's all about. So, yes, thank you. Comments from other colleagues in relation to sort of the overall IMS and VAC strategy that John has outlined there?
Yeah, can I?
Yeah, Mercy.
Sandra, can I ask you a question? So when you discuss immunisation with the people that use your centre, what kind of misinformation do they have, or what kind of things do they want to find out and know about?
Well, there's lots of superstitions
Right.
for some of our group around medication, because a lot of them have grown up with localised remedies, homeopathic remedies. And one of the things that they are most concerned about is what is in that vaccine. And can you tell me what's in that vaccine, which obviously we can't, and we don't try to, but we do say to them, talk to your GP or talk to the pharmacy, because we know that the pharmacist is another place they can get information from. But people are actually quite anxious about taking like flu vaccine. When we've said to them, take the flu vaccine, they said, but I never have flu. And everybody I know that takes the vaccine gets flu. So it's some of those things. And it's also, I think as well, there is this thing around Google diagnosis that is becoming a bigger problem as our older generation become more skilled in using Google. You have lots of Google doctors, yeah, and we're saying to them, no, go and speak to your GP or go and speak to your pharmacist, because some of them will come and say, oh, I've got this, they've advertised this new medication and it's supposed to be great, and I'm like, no, go and talk to your pharmacy, because taking something that you don't know about can have contraindications for what you're already on, and you should never introduce something. So there's lots of stuff going on, and it is a changing way of people accessing information that our elders didn't have access to all this information before. So it may actually be causing more problems than it's resolving, having access to all this information on the internet.
So community pharmacy, do they have more trust in that, or is it more accessible for them? Would they go and ask the pharmacist?
The reason I'm introducing the community pharmacies, because a lot of them don't realise that they can go to the pharmacy and they will say, well, I've waited weeks for a doctor's appointment and all I can get is a phone call. But in the meantime, they can be going to the pharmacy and getting the answers rather than sitting there waiting for a doctor's appointment and increasing their anxiety.
Jamal.
Just to follow up from
As
that.
a pharmacist.
As a pharmacist, and I know the number of patients that ask about all medications and vaccines specifically, and I just echo that it's a really reliable source of opportunity in pharmacy that we should maybe leverage even further. And I know you said you've got additional sites and more access, not just for information, but for the vaccinations themselves. There is a programme, I know you've got that in there, but I think that can be just knowing what the pharmacists do. There's room to do more there, I think. But I had a comment and a question. Just building on your last comment there, really interesting on information and misinformation. It's interesting that I was actually with the director of Google Health recently, and actually the exponential increase in people searching for information. And whilst there is a lot of misinformation, there's actually a number of GPs, clinicians, healthcare professionals that are posting a huge amount of reliable, good information, which we potentially should be referring people to. And so I think there is something about information as a determinant of health, and how we go about helping that journey to say actually there is reliable information out there which opposes the misinformation. But the question I wanted to ask was about pregnant women. I noticed in there that on flu uptake is particularly low. I don't know if there's anything we need to do differently just on that specific flu uptake for pregnant women that you're doing or think about, just maybe to John more than
pregnant
anyone
women
else.
aren't really part of our clientele that we deal with, but through the elders, they will have their children or their grandchildren who are pregnant. It's all we can do is pass information on to them to cascade on. So we use it like a sort of a ripple effect. We give them the information, we talk to them about some of the issues, and then they can have the conversation, because what we find is conversation in the lounge, in the front room, over dinner can be more powerful than the things that we run at the centre.
Yeah.
That's very, very true. We know that families actually are one of the, we talk about misinformation, but actually families are one of the key sources of information, cross-generational both ways. And, you know, if I speak to young people and say, well, where'd you get your advice from? Actually, really surprisingly, but 9 times out of 10, it's their mums. It's not from the internet, it's actually from their mums. And, you know, that is sort of quite astounding. I'll come to Charlotte, then to Vanessa, and then we're going to need to wind up this item. So Charlotte.
Yeah, just quickly to come back to your point, really, really important. So we actually have now, because of our community engagement and the information and intelligence we get back about how people are using Google and other search engines, we've actually invested, with John's support, in Google Search, so we can track what people are searching locally, and then we use those, you'll know this, we use those search terms to then put our NHS reliable information online for people to see it higher up their search function. And pregnant women again, so how we use our kind of community engagement funds is we look at our target groups, because I think we know that, you know, if there are 1.5 million people in South West London, we cannot target 1.5 million people. So we decide with John's team which particular groups of the population are we going to target, and then we work with particular groups in the community to find out through our community engagement leads, where are these groups in the communities? Can we give small, like a few £100s to particular groups? So for pregnant women, we use Baby Zone in Croydon a lot. So we have a real map, if you like, of channels and avenues that we can get to different populations, but we have to be really targeted for it to be effective.
Vanessa.
So the whole conversation has been basically, I think, about how our population trusts what we tell them, right? And then we had the conversation earlier, didn't we, about our response to the 10-year plan and the shifts. And one of the things that I think is potentially missing or has been talked about is our contract with our local population. That you know, how do we persuade them that we're honest and truthful, and they can work with us. I'm rambling a little bit, but it's true for the detection of cancer, for the prevention of the uptake of immunisations, and I wonder if we need to do something more rounded about that as a whole subject area that could tackle a range.
Vanessa, I think
strategies.
what we definitely need to do, and I think we sort of vaguely mentioned it currently in the slides, but when we put in our submission, we need to major on the need for engagement to continue to build trust. I think many of us were surprised when we were rolling out the COVID vaccination at just how untrusted certain parts of the community felt for us in the NHS. And actually what we also learned was there were often good reasons why that lack of trust had come about. So we mustn't lose that part of the agenda. I'm going to come to Sarah for final comments.
Yeah, so I think it is worth going back to the 10-year plan discussion. You know, one of the highlights is around moving from treatment to prevention. Vaccine and immunisation is a big part of that prevention agenda. And what we are seeing from John's presentation is uptake going down around our vaccines and immunisations for many different reasons and within many different groups. What I would say is that we have to focus on, we've talked about a small number of things, and definitely vaccine and immunisation should be one of those, because it has to be a priority because it has a massive impact on the health of the population. In order for us to do that locally, I think it's important that the board has sight of what's going on with IMS and VAX, and what we're going to do in my senior management team is have a regular report on the uptake, a very regular report on the uptake, and what we are doing in order to increase that, because I think we did that a lot during COVID, but I think we haven't maybe had the oversight recently of what's going on in that detail, because we had a really good reason at that point, and I think that we need to get back onto the wagon of grip of knowing exactly what's going on immunisations and vaccines, and really trying to make sure that everyone in South West London that wants one and that can get one should have a vaccination or immunisation appropriately.
Sarah, thank you for that. I think that's a really good point to end on. Just sort of an observation. In my time on the board of NHS London, that gap that you highlighted between London and the rest of England in terms of vaccine uptakes, by the end of the Strategic Health Authority's life, that gap had largely closed. And that, from my understanding of what we did, was largely driven because we had an ongoing focus on performance managing the delivery of vaccines. So really pleased that that's something that's going to be going to SMT. I think that we need to make sure that we need to have a conversation about what would the appropriate cycle for that to be referred up to this board, so we can keep sighted on it. And I'd like it to be a broad range of vaccines. So we include HPV, we include older people's vaccines, and we include some of the childhood immunisation, so that we get a picture of what's happening, and we can monitor that. I think that would be really important to keep a focus upon this area moving forward. So thank you very much. We are now going to take a break. It's a 10-minute break that we have at this point. So we will come back at 22 by that clock. So 20 to 4 by that clock.
One that didn't work.
Okay, we'll now make a start with the meeting. So welcome back, everybody. We are at agenda item 6. So I'm going to ask John to give us a brief introduction, but before doing so, just a big welcome to Martin Ellis, Chief Digital Information Officer. Welcome, Martin. John.
Thank you, Chair. Apologies to people. I know you're probably getting bored of the sound of my voice. Even my mother has decided to switch off. But this is the second presentation today. And I'm really pleased that we can bring digital back to the board today. So those of you who've been around for the last 18 months will have heard our initial conversations back in the day about cyber. Where we went to audit committee, and then we followed that up with our data strategy earlier this year. And now we're back with a wider digital strategy, which Martin is going to take you through in terms of how we developed it, what's in it, and then there will be the opportunity then just to consider some of the themes in our digital strategy. It seems really opportune for us to talk about digital in its widest sense today, particularly as the government has given us a really clear sense of the direction of travel in terms of the 3 pivots, in terms of analogue to digital, hospital to home, and indeed treatment to prevention. And every one of those is reliant on getting the basics of digital right, as well as adopting some more of the innovative stuff. And we've already heard about the positive role that digital could play today in some of the conversations we've had with Royal Marsden partners with regard to their cancer programmes, and we touched on a little bit in terms of immunisations and how we're working with data. So I'll try not to steal too much of Martin's thunder, and then we look forward to having a broader conversation about what we have come up with. So thank you.
Thank you, John, and good afternoon, everyone. And yes, I am doing Movember, in case you're thinking, what's that below my upper lip? Okay, thank you, John. So most of you will know that we already have an existing digital strategy, which was signed off in 2021 by the equivalent board of this board. And this is an evolution of that strategy. So we've been delivering that one, and we've grown it to more depth and taking on the latest sort of outside influence, etc. So the purpose of this document is to set out the strategic aims to improve healthcare using digital transformation and innovation over the next 3 years. And I'm sure you've been talking about the Secretary of State's 3 aims of shifting from treatment to prevention, hospital to home, and from analogue to digital, which is implicit in this. So we have a vision statement set out in the new strategy, and that's for South West London. Our vision for South West London is to empower our residents to manage their health and well-being with confidence, knowing that health and care professionals will have accurate and timely information at hand to provide the best care when needed. And very much about empowering patients, having that focus. But to do that, we need to have a few things in place, and that is a robust digital infrastructure. So making sure that the basics work, so you can access Wi-Fi, you can use your laptop, you can communicate with others. Those are key sort of foundations going forward for us as a system to be able to function and to thrive. We also need our records to be able to talk to each other. So if we have patients moving across the system or clinicians moving across the system, they need to be able to have that flexibility of mobility, and so that information is available at the point of contact. And we need to understand what the future delivery models are going to be like, so we can factor that into the development of future EPRs. You will recall earlier this year we brought the data strategy, which sets out how we use data to improve outcomes and service efficiency and productivity, and using data to harnessing data for better care delivery. So we'll be pushing hard on delivery of that. Empowering citizens is at the centre of this strategy, so support self-care and access to health records via digital tools like the NHS app. And we've brought insights to bear from across communities to help inform this strategy to what do we need from public, what does the public expect and require in terms of this strategy. And innovation is also a cornerstone for our digital strategy. So how do we encourage the use of new digital technologies to improve service delivery and patient outcomes? I'm sure everyone's talking about AI, artificial intelligence. It is the latest buzzword, and it's got some fantastic opportunities, but we need to make sure we implement it safely and securely. So we need to develop an adoption framework for AI so we can do that. And we're working in conjunction with South East London ICB to come up with a framework. But on the broader innovation, we need to be able to foster innovation through collaboration and adoption, but we need to be able to trial things, and those things that work, we need to take them to scale. I don't think we've been as good at that as we could be going forward, and incorporating that into broader transformation. So what are the challenges we have? I think it'd be fair to say, and there's lots of empirical data around this, that the NHS has a varying track record on delivering large digital programs to time and budget. And I think people would recognise we have our own challenges in South West London on that. We also, in terms of delivering the benefits of this strategy, it requires each organisation to participate, but local priorities might compromise that, so just need to be aware of that. Workforce is a challenge in digital and data roles, because we're competing with the private sector, who often pay more, and more broadly, I think we don't have as many skills in how to do digital transformation. And funding, you probably realise that I'd raise that. There isn't really a budget for this that I could say, this is what we're going to do, but we know that funding does come from national sources for things like infrastructure, for things like patient record systems, and for innovations like AI projects as well. So we expect that to flow, particularly given the narrative we're getting from the centre at the moment. So how will we deliver that? We're working on detailed delivery plans. So think about the infrastructure plan. You'll see in the document, we have a blueprint for infrastructure, so a single way to deliver infrastructure across South West London and how we migrate all onto that infrastructure. So we're working up the 3-year plan for that. We need to have successful project management capability so that we can ensure that we do deliver programs to time and date and improve that. Having strong leadership and governance is really important. So we've got a digital board that reports into the senior management team of the ICB, that reports into this board. So leveraging that governance is really important, and monitoring delivery, etc. This plan is aligned with South West London Green Plan and the infrastructure strategy, and that will help us to make sure that we get the most out of our estates and do that in a sustainable way. Innovation adoption, I've talked a little bit about. We should be using partners in our system to help with innovation, like the Health Innovation Network, the HIN, as a partner whose role is to support digital innovation and transformation, and develop that and enhance that framework for how we adopt innovations by trialling and scaling those things that work. And we've been working on a digital workforce plan as part of a broader London programme to develop the workforce for digital and data. And some of you'll be aware we have a Digital Pioneers programme that we're in the 2nd year of, which supports people to learn how to do digital transformation at the front line. So 40 people from across the ICS who are delivering digital programs at the moment are on cohort 2. Cohort 2 meets again on Friday. So that's been really successful program so far. But it's only part of what we've got to do. I think there's probably need to do that at a more senior level and expand it further. So I'll stop there and just ask the board to approve the refreshed digital strategy, and note that a fully accessible version of this document will be created on approval.
Thank you for that. Let's take some comments. Jamal.
Yeah, I don't mind starting. Thanks, Martin. Really good strategy, actually, built on a lot of foundational work. to try and layer in activities as you go forward. My comments would be, I agree with you, and I've got a couple of questions. I agree with you on scale adoption, and definitely something about stabilising the existing platform, which actually came up in yesterday's conversation as well, somewhat. The questions I had is, for us to deliver some of this ambitious transformation activity and kind of shift the leadership, most transformation programs, in my experience, are not short. They're normally 2 to 3 years, maybe longer, to establish. And so it seems to me, I don't know if it's a question or a comment, but it seems to me we need to have a different way of maybe approaching some of our cost-saving programs at either local level or at system level that allow us the ability to introduce longer-term programs, so 2 to 3 year SIP programs rather than 1 or 2 or more of those. I just wondered what your thoughts were on that. And then the second point would be, you said there's no money. I'm just keen to understand, how do we invest? There's the HIN, there's the NICE, there are King Health Partners, there's other models out there. How do we create how do we create the space and time and opportunity to allow investment to come in?
Okay, thank you. So on the latter question, I think that's something we've got to do, work with our partners in the system, look at opportunities to be able to do that, to allow external investment, obviously within sort of the boundaries of what's appropriate in terms of NHS finances, etc. And I can't recall what your first question was now.
It's more about how do we think more broader, how do we think more, whether it's at local borough level or area level, or even London level, how do we have a longer time frame in our mind over cost-saving programs, which may be a route in to bring in some innovation?
Yeah, so from my experience, it comes down to an investor-save business case type approach. So how do we identify where the opportunities are that digital is going to support a cost saving, and use some of that saving to fund, the implementation, and that's more likely to be a more sustained implementation as well, because through that process you're redesigning the services as well as putting in an innovation. I think what the NHS has probably not been so good at is putting in something like that and stopping something else. And we tend to have lots of layers of things in the NHS, I think that at the centre of it should be how we redesign services, and digital enables that, and that deliver sustainability and higher productivity.
Thanks, Martin. I'm going to bring Sarah in at this point, and then I'll go to Jo and Jacqueline.
So I do think it's really important that we do look at how do we make long-term transformation in the NHS. We've always worked from year to year, which I think we know has led us into a position where actually we can't make that long-term investment, and therefore the transformation that's required. Part of what we're doing in the missions board, which you will be joining, is we are looking at, we do need to short-term deal with our financial problems in South West London, because we have a deficit that we need to solve together, but we're also looking at a longer-term financial plan. And I think that one of the things that we have been good at in some respects is trying to explain how we might get from where we are now into a future look as South West London into what we need to do. And I do think that digital is a key part of that. So we're trying to develop a sort of 3, 5, 10-year plan that will be supported by the national 10-year plan as well, that describes what's the transformation that we need to do in order to, number one, transform our system, but also to become more sustainable both financially and clinically. So I think digital will be key to our success in that. So, we welcome your input into the work that we're going to be doing. We are at the start, I think, of that 3, 5, 10-year sustainable plan, but I think there's huge opportunity in us doing that. So I think you're absolutely right, but we have to look longer term. Hopefully, as we are being promised by the government, they will also look at us longer term and start to give us budgets over longer than 1 year, because that's one of our problems. We live from year to year with our budgets, and if we can get a longer term investment in the NHS that we understand for a period of time, it allows us to plan long term.
So thank you for that. That's really helpful. Probably worth noting that part of the work of London working together is to try to seek to establish a London Transformation Fund, which would be substantial. That would include Treasury funding, but it would also critically include funding from other parties, third parties, to boost that. So in line with the Chancellor's view about public sector investment being a lever for private sector investment, we think that principle will apply in London. We know that the London Regional Director is having conversations with NHS at a national level to see whether or not whether the Transformation Fund in London could be pump primed as an example for the rest of the country on making investments in the digital space. So that should not be a barrier. But I think critically as well, and the London Transformation Fund would be prioritising its investment in digital within a primary care space. And there's a really strong rationale for that, which is that it is much harder to construct a business case for investment. So, Joe, I'm going to be coming to you in a moment, but you are currently piloting ambient technology in Kingston on behalf of the whole of London. That technology, we think, would be transformative in a primary care setting, currently piloting it in north central London. But we do not think that individual practices would have the capability to make that level of investment. That is slightly different. If it really is generating a 20% productivity gain in the acute sector, which we wait to see, then we would think the business cases in the acute sector are beginning to write themselves for that level of investment. But if I could come to Joe.
Yeah, it's sort of related to that point, but our experience of that ambient AI pilot, which is in an outpatient setting, is that it allows us probably to add another 2 patients to an outpatient clinic, so that's where the 20% comes from. But then, in addition to all of that, you've got all of the other systems that we've currently got around dictation and various other things that you could potentially look to strip out. So I think, you know, it has a lot of potential. I think my sort of linked point to that is, and I welcome the strategy, Martin, I think it's sort of, you know, really clearly laid out. I wondered whether we, and it may not just be related to digital, but do we really need to have a sense of the value of our data and our contribution to the development of these things, and how do we ensure that that value is sort of commercialised and monetised where it's appropriate to do so? Because that could be, you know, another source of funding and investment. And yeah, we are part of this ambient AI pilot, and the host organisation is an equity shareholder in, you know, our AI partner. So should we think about how we become a bit more commercial and savvy in this space to sort of attract investment in a whole lot of potential for research, I'm sure, as well, if we appropriately make our data available. But, you know, how do we sort of use the value of our contribution and our data to attract investment?
I think that's a really strong point, Joe. I suspect Martin may well want to say something when I've had some other contributions back on that whole issue, but that feels like a really strong and important point. I'm going to go to Jacqueline, then to Annette.
Thank you, Martin, and a great strategy. So it's got everything in there I'd expect. I think, firstly, you'll be pleased to know that in our response to the 10-year plan, we've added something in about capability around digital, because I think it is, as we've sat around here, as it is, I think we think it is a thing, and you certainly see it in organisations in trying to deploy things quickly and knowledgeably. I think the second thing I wanted to talk about was about the engagement of our staff, particularly clinical staff, around deployment of these things. So we're just about to deploy the teledermatology. I cannot tell you the pain we have been through to get actually everyone to agree what we're using, because it's about general practice to dermatologists who say, we can't possibly have that because the image would not be good enough, and we're too busy. So it's taken a long time, but we've got there after about 18 months, 2 years, to actually use one platform to do it on, which is great. But the bit, I suppose, I just want to make sure we run through this is, regardless of where clinicians are, primary, secondary, integrated care, they have to be a big part of this. And I suppose I just want to make the point, in there because it's very much a digital strategy, and I'm not sure it quite recognises the part to play that we all of our staff have in actually making it a reality, and we're making it a reality quicker rather than what some of the pace we tend to go at sometimes. Thank you.
That sounds like a chief executive of a trust which is about to embark upon a major investment in EPR and rolling that out.
We're not embarked, we're halfway through it.
Halfway through, yeah, indeed. Yeah. There's more pain to come, Jacqueline. If I can go to Annette and then Nicola.
Thank you, Mike. Thank you, Martin. A really, really comprehensive strategy. I enjoyed reading it yesterday evening. I don't think I got through all of it, but I got through a lot of it. And I really welcome it. I just would like to make a couple of points. The first is around data. So we have a lot of data in the NHS. It's really hard to get sometimes. It's really hard to access that data and be able to use that to do some of the things that we're talking about, like research, like doing the population health stuff that we'd like to do, some of the cancer work that we're talking about. And I think you have said something about that. I think it's key that our data becomes more accessible to clinicians on the ground, but also to our organisations, so that we can use it in the best possible way. And secondly, this is an area where there are a lot of seductive products. It's fast moving, everyone's got the best product, everyone's going to solve the next problem. And I think the only way for us to ensure that we use the resources that we've got, or funding that we can get in this space carefully, and ensure that we're not having to repeat products over and over again to solve problems, is by us taking a systematic approach to testing them, or using the evidence of how they've been tested elsewhere in the right environments, because it's often that something has been tested in an environment which is not then the intended environment that you're purchasing it for, and it doesn't provide the same results. And so I think I'm really, really supportive of us moving to a much more digital environment and having better products and improving our productivity. But I think it's also an area where we potentially could waste a lot of resource if we haven't got a very systematic evidence-based approach. Really great.
Thank you for that, Annette. And again, part of the work that London is doing, because some of this is at scale, is looking at how we can provide that sort of testing environment. And interestingly, we're also having conversations with the Turing Institute in that space that actually undertake an awful lot of that work, and we're potentially building a partnership with them that would be initially for London, but potentially a national resource further down the line. If I could go to Nicola and then Karen, and then we're going to have to wind up this. So I'll come back to you, Martin, for any responses, and then final words to Sarah.
Cool, thank you. Yeah, I would agree with both of Annette's points from a kind of primary care perspective. I was going to pick up the point that you made, Mike, about the ambient AI in primary care. Because I think if you think of the volume of consultations and patient interactions, there could be enormous benefit there. And so I would really like to see us looking at that. And then sort of two questions, really. One is about the digitisation of medical records in general practice, which I might have missed in there, but I couldn't find it. Because there's a room in every practice which is taken up by medical records. Think of what that could release. And then the other thing is just like recognition of how difficult your role is, because digitisation is not an end in itself. It's only useful if it achieves something for us as a system in our health and care system. And how on earth, please tell me, are you going to align with all these work programmes, all of these folks that are, it's a busy space, right? And we'll all want a bit of you. So it's just something about how can we all make it easier for you to be in the right conversations to make sure that you can, influence at the right stage.
Fantastic, Nicola. You didn't hear about the piece of technology we're buying, which means that we can clone Martin. Karen.
So one of my points is linked to what Nicola's just said, but I'll come back to that. So two things for me, Martin. We've been talking, haven't we, both last night in the engagement session about the 10-year strategy, and then we also had a conversation in the board about what are the things that are going to enable us to move from analogue to digital, and what are some of the challenges. And we talked about, it's a very crowded space digitally, isn't it? And in your strategy, you talk about the rationalisation of some of those systems. So I wondered if you could talk to us a little bit more about that. And then secondly, I suppose my question is, if we added up across our organisations, how many digital strategies do you think we'd have? That's not, that's a rhetorical question. Because I suppose unless we get to a point where we have one vision and one version, we're always going to have that potential to have lots of different solutions pulling against each other potentially. So I was also just going to talk, I was going to ask you to talk about how are they aligned, how are the digital strategies of all of the organisations aligned to this, so that actually we end up having one thing to aim towards for everybody.
So, Martin.
Okay, so if I go in reverse order, so I think that's really important, and I highlighted that as to realise the benefits, everyone's got to pull together. And I think that comes down to personal relationships and partnership working as much as it is to having a document for that. So I pulled together the CIOs as a group, and we collaborate together. A lot of the content for this is built up from the bottom with engagement from each partner. So it's not something we did in isolation in this building. It's something that we've done as a system. We've created this plan and strategy. So I think that's really important. And in terms of rationalisation, I mean, we've got so many systems out there. I mean, if you just think of the main EPR system we have for acutes, there's three instances of that. So how would we sort of bring that together? And then all the different ologies have got a system that sits around it. Could we rationalise that as well, as an example? Because the more systems you have, the more difficult it is to integrate and have availability of data. So rationalising and simplifying has got to be a really critical sort of direction forward. In terms of how to get the best out of me, I think, and access to me, I think, Nicola, I think it's there is a lot on this agenda. And I think we've got to prioritise. We've got to make sure we're doing the right things first. And I would also say it does need to be embedded in broader transformation programs, and not just a digital thing on its own. It's got to be a broader transformation program. And I've created a team that supports that approach. And digitising medical records, I haven't got into that level of detail. We have already done some of that. So we've trialled that with about 20 practices, I think, and it's been successful. Has a cost associated with it, but it's something we're exploring through the estates strategy work as well, because it does free up capacity from a state's point of view. In terms of the adoption, yeah, I mean, I think I'd pull it back a little bit to, if we're doing transformation, what are the things we need digital to do? Understand the requirements of digital solutions, and then make sure we've got the right solutions to support that. Just as much as sometimes we do need to have disruptive innovations as well that are going to turn things on its head. But so it's both sides of the coin really. Accessibility data is really important. The data strategy sets that out and a plan on how we deliver that. And staff are at the centre of this, and we've got to look at how we improve the staff experience for the use of these systems, as much as getting them involved in it. If it works, they're going to use it, essentially. So we've got to make sure we get systems that have good user interfaces, etc., and feel good to use. And then I just want to pick up what Joe said about is there a commercial opportunity? I don't think we've been very good at that in the past. We've supported technology vendors to create solutions with our input, and we don't have a stake in it. So we need to change that. And if we're going to work with a small or medium enterprise that's just learning in the health market, then we should be negotiating a deal with them, so we own part of that IP, the intellectual property. And then just going back to Jamal's point, I think NHSE have picked up on what you're alluding to, which is around that longer term. And for the first time through the frontline digitisation program, they set a 3-year capital plan, which we normally have a 1-year. So I think they realise that actually there's not something you can do over a single year. You've got to do over 3 years. So they have woken up to that. And it's really critical, because without that, it's difficult to plan forward and to drive big programs forward with confidence.
Martin, thank you for that. Sarah, final words.
Yeah, I'm just going to repeat a little bit of what I said in my senior management team when we were discussing this, which is that although it's wonderful having a Chief Digital Information Officer, I remember a few years ago when it was acceptable to say, well, you know, I just don't do digital because, you know, it's the technical part of it. And it used to be the purview of the techies, didn't it? Now it is what we all do. So in response, I think, to Nicola, is we are all responsible for digital across the whole of the NHS because it's a key part of what we do. It is one of the 3 shifts. It is something that all chief execs I know are engaged with, and all staff will need to be engaged in as we move forward. So it's everyone's responsibility to make it a reality. And then I'd like to thank Martin and the team for building a strategy that I can read and understand, because I do think digital doesn't have to be about the techie. It can be about what is it we're trying to do and the outcomes we're trying to deliver, and I think that's what this strategy does. So thank you very much for that, and I would fully support it.
Fantastic. Martin, I think you can take it as read that we are supporting and endorsing the strategy. And thank you to you and your team. Jacqueline, we're finishing this item, is it?
No, but we've gone through quite a few strategies today, and I do wonder whether those, now they've been done, we can actually take them through our boards as well, because so it'd be really helpful to get copies of whatever we do here, so we make sure we get them through the boards too. Otherwise, we just do it in this room, and through the CDIOs, and the boards don't get a chance.
Fantastic. Thank you for that. Thank you for that. Ben, can we look at how we can systematise that so that we have a sort of proper conveyor belt into our providers, and that we give them advance notice of what's coming to us and when it's likely to land with them, because that will help them with their corporate diary planning. Great idea. Thank you, Jacqueline. We're now going to move on, and there's a clue in what I say, to a rapid look at, first of all, our partnership delivery agreements and then our medicines optimisation. Substantial reports in here, which we have all read. Karen and Jonathan, over to you.
Thank you. I'll take it in the spirit of speaking fast and saying fewer words, Chair. So, partnership delivery agreements, just to explain what they are, back in 22 when the ICB was set up, a number of functions we agreed would be delegated to the 3 provider collaboratives, the acute provider collaboratives, the mental health collaborative and the Royal Marsden Partners collaborative, and to Place. We have spared you lots of reading because we could have shared the documents with you. We did at the beginning of the life of the ICB, but since then we tried to give an annual summary of progress that's been made, and what you've got before you is the annual summary. It basically updates for changes in the last year that we've seen in guidance, the learning that we've had across the system from 2 years of experience, and clarity on roles and responsibilities. There's clarity about the link into quality and performance oversight committee and finance and planning committee, which I think is important for the board to be aware of through regular meetings with the provider collaboratives in place. A very pretty illustration of how we're all working effectively together across the ICB to make this happen. And then there are summary slides. I won't touch on the RMP one because we've obviously covered that at some length today, but it echoes much of what Callie and his colleagues said earlier. There is an update on the acute provider collaborative and the achievements over the last year. Many of those will be familiar to people, but the driving up of efficiency and delivery to secure more elective activity, and community diagnostic centres might be 2 illustrations. I could spend a lot longer. I won't, and I'll hand over to Karen to cover the mental health and Place ones.
And again, just in the interest of time, so I think Vanessa came last time with Amy and presented the Mental Health Collaborative, but just to pick out a couple of things. So the work that the collaborative have done on its first South West London mental health strategy, and now working to deliver that, taking on additional responsibility for phase 2 of patients with complex care. And then not stopping there. So another thing that's in the document is the fact that we now have a quality transformation plan that will also then go through and seek to improve mental health even more. in place, I think we're seeing huge amounts of improvement through the work that happens at place, and you've got lots of examples which I'm not going to go through. But PCNs are developing through our place collaboratives. We've got better responses to some of the national targets because of some of the work that's happening, and we've got better engagement. So I won't go through all of the examples, but lots that are happening at place through the place delivery agreements, giving focus and clarity to what's expected, but achieving those well.
Thank you for that. I propose we note those reports and the continued good work of our various partnerships. We haven't heard quite enough from John today, so we're going back to John for medicine optimisation. And again, this is a very, very rapid report, isn't it, John?
Chair, I've no idea what you're talking about. So thank you for listening to my dulcet tones for a third and final time, hopefully today. I'll take it as read. You'll have the papers. A couple of points I will come back to, but I'm just going to take the opportunity to introduce Helen Porter to us as a board. Helen is our new chief pharmacist who joined us in September. Helen, would you just like to say a few words about who you are, where you've come from, and why this will matter? And then I will move rapidly on, I promise, Mike.
Good afternoon, everybody. It's really great to be here at board. So where did I come from? So I joined the ICB in September from the same role in Sussex, but prior to that, I came from provider trust land. I spent a long time in acute providers, and then I joined the Royal Marsden. So I have delved into the South West London territory, and I was just noting a couple of colleagues around the table in terms of CEOs that I work with. Prior to that, I have had a big role in terms of regional and national workforce transformation that I held with Health Education England, now NHS, EWT and E. So I come predominantly from a provider trust background with a real passion for workforce and workforce transformation and how that is key to everything that we do from a service delivery perspective. I think for me this is a great opportunity for medicines optimisation to really showcase and raise awareness of what we can do in terms of optimising medicines and what impact that has on the health and well-being of our populations. And I think John will talk you through the slide deck, but this is just a sort of a teaser on what we've been doing and we can grow and sort of develop in terms of what the art of the possible is in terms of our ambition for the population of South West London.
A big welcome. It is actually really good to have you with us, and it's really good to have a chief pharmacy officer. It feels like we've now completed our top team in terms of clinical roles, and it's really good that we are, of course, seeing medicine optimisation as actually cost control, but actually it is much, much more than that. This is about getting the right treatments for our patients, and I think that was reflected in the paperwork. John, you're going to give us a brief intro.
I will take 30 seconds. So I will take that the paper is read. Lots of people don't really understand what's in meds optimisation, so hopefully by bringing this paper it'll give you an idea of what the team of 50 colleagues do. We've been through a management cost restructure, which was difficult for my colleagues, and I just want to acknowledge that. But we've brought the team together when previously they were all based at place, and that's allowed us to think about meds optimisation in three ways. We have a clear focus on primary care and community care, and that includes not just working with GP practices, but also the opportunity of working with local community pharmacies, because we see a real opportunity there as general practices under pressures to provide services in that space. By creating a medicine safety and value team, we can really start thinking about some of the safety risks, whether it's phenytoin or some of the other things that are causing us challenge as a system, so we can focus on those. And then the final thing we do is we have to think about the money. We have to think about how we use our resources appropriately. And we've got the medicine cost and value team. That is a digitalised approach, particularly around our high-cost drugs. We are one of the few systems in the UK which uses blue tech successfully. So we have got those controls in place which allow us to sort of have as much money as we possibly can to support high-cost drugs, whether it's in cancer care, rheumatology or gastroenterology. So really happy that we've got those processes in place. There's a slide there which shows how much money we spend on medications in South West London. We've done a little bit of benchmarking benchmarking by place. An important caveat, just because one place spends more or less than another place doesn't necessarily make them good or bad prescribers. A piece of work we're going to look at over the next year is going, right, is there a link between quality, value and outcomes and the cost of our prescribing? It's just there because people like some benchmarking data and it's useful to think about it. We've stuck down some of the work we've done so far over the past 6 months, highlighted some of our key objectives over the next 6 months, particularly around some further transformation. Big pieces of work for us in terms of delivery as an ICB are hybrid closed loops. That's the artificial pancreas kind of language. It's really vital that we get that right, because if not, part of the car and the national team will be down to me like a ton of bricks. But that's a fantastic opportunity to move treatment from hospital to home, because we will enable people with type 1 diabetes to actually live a much better quality of life and have much better outcomes. And the other thing we're paying serious attention to in terms of treatment to prevention is the obesity medication. We're already working with Ozempic in South West London, but tirzepatide or Mounjaro is coming down the tracks. NHS England and NICE are working on a framework which might be quite restrictive, and we will make sure that we'll be in a position to deliver that when that NICE technology appraisal appears probably in the next month. But we're seeking to go further and faster, thinking about commercial opportunities, because we really want the people in South West London who struggle with a healthy weight to have an opportunity to embrace some of this new medication. It won't be medication in isolation. It has to be part of a wraparound process which includes social and psychological support. But this can be delivered, and it can be delivered digitally, and it can be delivered through community pharmacy and absolutely general practice. So that's the kind of thing which will excite us, we think, over the next 6 months. So hopefully that's enough from me, and hand back to you, Mike.
That was really exciting, actually, surprisingly, when we're talking about medicine optimization. But no, I mean, that thank you. One of the things, so I think the anti-obesity stuff, you and I have had lots of conversations around that, John. I think it provides a really exciting potential. I think we've created some good work here. You may want to have a chat with Omar Daniels when he starts with us, one of our new associate NEMs, not least because he's been working with some of the digital companies that are working on medicine optimization, which is looking at systems that actually support the shift to generics, but actually also make sure we get the right drug optimization, support the antimicrobial resistance strategy, including in pharmacies as well as in general practice and in acute sector settings. So quite an exciting world. What I should, of course, have said in my chair's section at the beginning of the meeting was how nice it is to celebrate World AMR, Antimicrobial Resistance Week, which we are in the middle of until the 25th of November. So if we can celebrate that now, I'm sure everybody will want to join me in thinking that. John, did you want final comments?
Final comment. So meds ops and exciting in the same sentence. I think my team would say our work here is done, so thank you, Chair.
Brilliant. Thank you, John. We'll move on to board committee updates and reports. Jamal, your first finance and planning committee update. Well, in fact, this is somebody else's.
No, I did yours. This meeting. No, I did. I turned up, and I think the following day I had to go straight into the FMP meeting. So listen, I'm happy to share a very brief update. We've got the report, so I'll take that as read, just to share some top highlights of some of the things we discussed. We discussed the continuing healthcare deep dive review. We had a detailed overview of what that was involved from a performance, finance, and workforce perspective. And a note that the committee discussed current performance as well as the key delivery risks. And the recent work with auditing 60 cases across the 6 boroughs. So some really good work there. We discussed the planning approach for the following year and the emergence of the new mission board, which will focus on integration and transformation activity over the next period. The committee also looked at the future board meetings with progress updates, including any key risks. We discussed the financial outturn. At the moment, the targets, as you may well be aware, is 120 million annual deficit. We're currently sitting on 86.3 million deficit, which is 7.4 million adverse to plan. So we looked at the key adverse position and the reasons that were driving that. And there was a couple of those were driven by industrial action, cyber attack and the Royal Marsden Hospital paediatric income was one of those areas. And particularly the committee discussed the ongoing challenges to reduce the overall workforce, which is part of the cost-saving programme overall. The three main, or two or three of the main risks to the NHS system performance were around, as I said, the recurrent savings and the risks around delivering that objective and the planned workforce reductions therein. We talked about the capital plan for 24-25 and noted that the spend at month 5 is behind by 36.5 million overall, partly because of the uncertainty in funding following reduction in the system envelope. And last couple of bits would be, we looked at the operational plan delivery in month 4, and I guess the summary would be South West London continues to perform well compared to other ICBs. There's a lot of detail behind that, but that would be the summary. And then from an ICB perspective, it's noted that ICB is on plan to deliver the 3.06 million surplus. And then the final bit would be, we agreed, as from an assurance perspective, a number of business case and contracts awards in line with the committee's responsibilities.
Jamal, thank you for that. Any questions for Jamal before we move on to Helen? Helen, to you.
Thank you. So Jamal just described the month 5 financial position. The paper within the pack, as we've moved on with time, is the month 6 position. So many of the themes are the same. I guess what I would like to just say is we do recognise that the NHS as a whole is in a very difficult financial position this year. The finances are incredibly tight across the whole country, and there are a number of systems that are finding it very difficult to deliver to their plans, and therefore we are all carrying a lot of risk in what we're delivering and what we're trying to deliver. As at month 6, in line with the paper, we're £7.7 million adverse, so that is a slight deterioration. That is partly because we received some income to support the industrial action impact, but not to cover the loss of income from industrial action. But we are now starting to see where some organisations are finding it more difficult to deliver their savings plan, and so are starting to slightly come off track. At this point in time, we have delivered £100 million worth of savings, but we are around £15 million off track year to date, and it is getting more difficult to do that as we go into winter. So we recognise that as a system, our biggest risk is around the delivery of the savings programme as we go forwards, and managing the inflation risk that we have, as well as the operational pressures which are through the non-elective pathway, which are made more pressures and require more staffing and making it more difficult for some of those reductions that Jamal talked about. But happy to take any questions.
Helen, thank you for that. I think that gave us a good flavour and an update on quite where we are in the financial position, which continues to be challenging. As we have all 5 of our hosted trust chief executives in the room, just a big thank you from the system for all of the work you're doing. But it's a thank you and please continue. So thank you very much. We'll move on to quality and performance. So Mercy, our non-executive chair.
Thank you, Mike. So the Quality Performance and Oversight Committee met on the 9th of October. I'm just going to give you 1 or 2 highlights from it, and I'm sure Jonathan and Elaine will add to quality and performance. So we noted the NHS Oversight Framework and Tiering update was that there was no change. Just wanted to say that we had quite a long discussion on children and young people programme and the update on that. John will be happy to know that we approved the Medicines and Optimisation Committee annual report, and we had quite a long discussion on that. And Mike, you will note that we also talked about antimicrobial resistance and the work that we're doing in the system, and we were pleased to note kind of the programme of work and the push to support that as well. I guess those are the only things that I really wanted to highlight from the committee.
Thank you very much, Mercy. We'll go to Elaine for quality.
Thank you, Chair. I won't repeat what Mercy has said, and I will take it that colleagues have read the quality report. Most of what Mercy has alluded to, there's more detail in the quality report. I think the only thing I'll draw attention to is the deep dive mortality. We had a deep dive on mortality across South West London, which was well received. It's the first time we've done that sort of report, and it identified a few issues. In particular, it looked at some of the suicide prevention work that's happening and where we're an outlier. It also looked at the mortality rates and elevated mortality rates in some of our trusts. Some of our trusts are part of a national data collection programme at the moment with this same day, I'm looking at some of the CEOs, the same day elective activity, and that data, the way it's being captured, is elevating the mortality rates. One of our particular trusts had a slightly elevated mortality rate before they became part of that programme. They've been very open and transparent about that. The trust have identified that themselves and are doing significant work around that, which is reaping some good results with some of that focused attention on some of the work, in particular around sepsis, some of the cardiac arrests work, etc. The data takes a while to catch up, so those improvements won't be seen until Q4 or into next year. Ourselves are working with that trust and MDT for the learning, and we will bring some of that work back. Our mortality deep dive report we shared with NHS England, the London region. We were the first ICB to present, and I'm delighted to say that we've set the benchmark. They were very impressed with the report and the detail it went into. And from that, we have agreed that we will have our own South West London local mortality group. We're just agreeing the terms of reference with that. I'm delighted that our Chief Medical Officer has agreed to chair that group. And that should, our first local meeting should be in Q4 in the new year. I'm happy to take any other questions.
Thank you, Elaine. Jonathan, we'll move on to performance.
Thank you very much, Mike. So just a very brief summary to draw out some positives and areas of challenge. So really good to see the increased availability of primary care appointments through the summer, a really important part of sustaining what we need to deliver so the rest of the NHS can cope through the winter period. So good to see that through the summer months, and good to see the strong performance as a system we're delivering on the 4-hour standard. Given the scrutiny St George's emergency department have faced in recent months, really good also, can I call out their really strong performance on the 4-hour standard, which is very impressive. And also to note, I know the paper talks about improving access to psychological therapies, which has improved, but one for me that stood out when I was reading the point was the early intervention in psychosis, such an important indicator, and how that has improved from the mental health trust quite significantly over the course of recent months. So those are some positives. And then I'll probably just pick 2 areas of challenge. So whilst we remain the best in London and amongst the best nationally on long waits for patients accessing planned care, we are not quite where we said we were going to be. We did deliver our revised trajectory at the end of September of 166 patients, but we'd originally set a higher threshold than that. Off industrial action, as has been alluded to under the finance report, played some factor in that, and we talked to the Elective Transformation Board on Monday about how we need to make further progress to eliminate 65-week waits as soon as is possible. And we set some clear timelines around that. And the second area, which is my perennial area of concern and focus, is just to note the 12-hour A&E waits, both for physical and mental health patients. So the trends are not moving in the right direction, despite an immense amount of work from so many people inside this room and outside of this room. And that, of course, is a considerable concern as we move into the winter period in terms of keeping people safe and providing timely access to care. So those would be my summary highlights.
Thank you for that, Jonathan. I think particularly on the long waits in ED and mental health patients, we may well want to get a report back at the next meeting, particularly on the basis of some of the conversations that our Chief Executive is going to be having in relation to the problems with Surrey and Borders patients particularly at the Epsom Hospital site. So we may well come back to that. I'm going to move on the agenda. If I could, we don't have our Audit Risk Committee chair with us, but Helen, would you report back on the meeting on the 23rd of October?
Yes, thank you, Chair. So the October meeting is generally the meeting where we look at progress reports from internal audit and also start to work with external audit to set up for this year's audit process. So they were areas that we covered. Key things to note though was we reviewed the board assurance framework and had a deep dive into cyber security risks and how as an ICB we are managing those and working with our partners to mitigate them. Further to that, we had a discussion around the Procurement Act and what that means for us as an organisation and when it's due to come in early in the new year. And finally, Counter Fraud presented an update and also referenced the work they were going to do this week, because this week happens to be International Fraud Awareness Week. Oh, there you go.
Wow, so not just World AMR Day, but Counter Fraud Awareness Week. It's such an exciting week. Yeah, I am. Well, I think it's tragic that I didn't know, but it's never too late to celebrate. Never too late to celebrate. Okay, so we will move on to Remuneration Committee. Mercy.
Yes, this was out of committee decision by members of the Remuneration Committee, and just we approved the very senior managers uplift of 5%. To October salaries and the approval of the application of additional spine points within the Gender for Change pay bands 8A to 9, and that money is given to us for those reasons from the NHS.
So we know who the Christmas drinks are on this year. Thank you for that, Mercy. Moving on to the Chief Executive's report. Sarah.
So I will be brief. I'll just take most of it as read, just so people know. Specialised commissioning will be coming back for a further discussion in depth in February to the board. Is that correct? February? January? January. In January, because we are expecting delegation to happen from April the 1st next year. So we will bring that back for a detailed discussion. Just want to highlight that we did have a South West London Dental Day that Mark Creelman organised as our executive lead. I know a lot of people came along to that. We do know dental access is a problem. We've taken on the delegated responsibility as part of optometry, dentistry and pharmacy, and I'm sure that there will be questions about that, but I understand it was a really good day. We recognise the problems with access, but people are engaged. We're trying to work through what we can do now that we have that delegated responsibility in order to increase access in South West London. And I would just highlight, just for one last time, let's not forget the 10-year health plan for the NHS, which is currently in development. There is a full engagement. I would remind the public that any member of the public, any member of staff can feed back into the national team. You just go on the website there, you can click through and you can feed back your thoughts on what should be in the 10-year plan, as well as organisations which as an ICB we will be responding to, and I know our organisations within the ICB will also respond.
And just on that, any of our local organisations responding to the consultation, we would greatly appreciate copies of those being sent to us, just so that we can get a sense of what's happening within South West London more generally. Jacqueline.
Yeah, we will share with everyone we'll actually do a response from the discussion that we've had at the ICB. The problem is it all goes centrally and we don't see it. So if we have everyone's, we can pull that together into our plan. Yeah. Yes, we will make sure. We will make sure that we do that for everyone.
Yeah. It would be nice if we were aligned. I don't think we will definitely be not the same, though. Yeah. But nice if we're aligned. Fantastic. Thank you. Can I just ask, is there any other business from members around the table? In which case I will formally close the meeting, and I'll now move to public questions. I have not received any written questions, but Wendy, I see your hand is up.
So, as I say, every time I attend here, my name's Wendy Micklewright. I hallucinate, I hear voices, I'm not ill, I don't take psychiatric drugs. I'm involved with a community group that's affiliated to the Hearing Voices Network. People have been in touch with me, several people. It's something that I mentioned last time I was here. They want support to come off their mental health drugs. I suggest to them that they talk to the people who are prescribing the drugs. It's a very difficult process. I would also draw your attention to the data that we've got under the Freedom of Information Act, which we've been gathering for more than 5 years nationally. It's a series of questions which tease out issues around sexism, racism, ageism and ableism. And from data that we got from Bradford in 2021, and it's a similar set of data from Bradford in 2023, which we haven't released yet, there seems to be a disturbing link between refusal of medication on mental health wards and restraints. I would suggest you look at that data from Bradford. It makes very disturbing reading. It highlights all the restraints and why people are being restrained, and that's often to do with medication. I would also draw your attention to the fact that North East London Foundation Trust, their management team are being held on manslaughter charges with regards to Alice Figueiredo. She was 22 years old. And when we're talking about risks, I think you need to be aware of that. I thought for a while about Alice, and I thought, what could we do differently? And I remembered the report that the World Health Organization released in 2021, which gave examples of best practice, which included the Hearing Voices Network, but it also included peer respite centres. A friend of mine, a similar age to Alice, who was struggling and wanted to end their life, they went to the Maytree, which is something that I've been mentioning for many years now. It is a little bit like a peer respite, but it has good results, but it's never been scaled up. So I think we need to, when you're talking about prevention, I think we really need to think of the social determinants, which I think was mentioned around cancer. There was also another case of Nicholas Thornton. He, like me, is neurodiverse. I'm dyslexic. He had several issues. He was held on mental health wards for over 10 years because there was inadequate understanding and housing. That's still going on, and it's been going on for a very long time. It's been 2 years since I came to the ICB and spoke about electroconvulsive treatment. The reason I highlight electroconvulsive treatment is because there's a petition with over 136,000 signatures, which shows that the people that the ICB serve, they have concerns about electroconvulsive treatment. In America, they've done a People's Assembly around youth homelessness, and I think we do need, people have mentioned we need a revolution in how the general public influence these situations. So in private, people have told me that they don't support electroconvulsive treatment, but here we are many years down the line, still happening. I'll leave the last word to my someone I consider to be my friend, Colin King. Dr. Colin King, he's set up a petition, and he's, I'll just read what he said. Hopefully that won't take too long. The petition is calling for the end of the Southwest London and Maudsley. He wants the name Maudsley removed because he says, quite rightly, that hospitalisation and traumatisation at Maudsley Hospital, where Maudsley developed racist ideas that I was inferior, leading to being diagnosed with schizophrenia and sectioned. There I personally experienced restraints, electroconvulsive treatment, overt abuse and discriminatory treatment. Maudsley was known for his eugenics theories alongside Freud and Darwin. He advanced the belief that mental deficiencies were endemic in certain races, classes, and homosexuals. assumptions that play into the racist bias of modern psychiatry and psychology, assumptions that have led to the death of Bennett, Riggs, and I'll say Senny Lewis. From the Mental Health Reform Bill of 2022, black people 11 times more likely to be diagnosed with schizophrenia, 5 times more likely to be detained under the Mental Health Act, 29% more likely to be restrained from the CQC, 8 times more likely to have community treatment orders. I don't know how familiar you are with community treatment orders, but I have a friend on one at the moment who's causing them a great deal of distress, because if they don't comply with medication, they're currently under depot, which is a very humiliating experience, and they're more likely to be detained on mental health wards. So I'll leave it at that.
Wendy, thank you for that. We will pass on to South London and the Maudsley your concerns about their name. Ben, if you could make sure that we do that. I don't know, Vanessa, do you want to say anything about the proposed new legislation in relation to mental health? That might be helpful to contextualise some of the comments that Wendy has raised today.
Absolutely. So, Wendy, thank you as always for advocating for mental health, and we work closely with Dr. Colin King on some of the work that we're doing around prevention of restrictive practices, which I think you know about already, but I can always share more with you. I was really pleased that the new mental health bill was actually got its airing last week, and that will see a significant change, the biggest change we've had in 40 years for the Mental Health Act, which will lead to a reduction in restrictions, particularly for those with learning disabilities and autism, which is really very important, alongside increased rights and advocacy for people with mental health conditions, and a review of the community treatment orders, particularly some of the early indications is the wrong word, but anyway, stick with it, is that it should lead to a reduction in the detention rates, particularly for our black and brown communities, which is really important in relation to the over-representation. So we fully support the bill, and we will make sure that that's reported here going forward. But we'll continue to work with you, Wendy, and Dr. King on his work as well.
And Vanessa, do you happen to know the timeline for the legislation?
Gosh, so the last document that I saw was that it will get, I think it's up to 6 to 12 months to get through, and then there's probably a significant lead-in time for full rollout. Wendy, we've regularly spoken around ECT here, and the board has given a position here, and I will continue to reiterate that position. I'm not ignoring your position on it. We just have a difference there.
I think we're talking about partnership. We're talking about there needs to be acknowledgement that this. I mean, there are 2 MPs that says that electric and voltage. It is very clear from the data. We talked about data earlier. It's very clear from the data that it's a sexist practice. And saying that you hold a certain position and ignoring people's realities and ignoring the data which has been provided, what other conclusion can you reach?
So Wendy, our responsibility as a mental health trust is to follow NICE guidance, which I'll continue to do. And I know that us getting into a debate here isn't going to be constructive. I'm not
well, the only thing I would say is that James Davis has written a book, Cracked, Why Psychiatry is Doing More Harm Than Good, and stated how modern capitalism created the mental health crisis. And
Wendy, I'm going to...
NICE,
Wendy,
yes, I'll just make this point about NICE.
I'm going to stop you now because we're not going to have that debate around this table. This is not the table to have a debate
around. Well, which table is the right debate? Because there is concerns about NICE and its impartiality.
Okay, thank you for that. Can I check whether there are any other questions from members of the public? No. in which case I'll close the meeting. I know that, Wendy, I know that Vanessa will be happy to have a conversation with you.
2 years.
Thank you all.